Okay, good morning. Welcome to the November 21st, 2025 California Board of Behavioral Sciences meeting. My name is Wendy Strack, chairperson of the board. And today we will be opening the meeting and immediately entering closed session to evaluate the performance of the executive officer. The open session will continue after the conclusion of the closed session. We will do item 14, call to order and establishment of the quorum. Members, during the roll call, please introduce yourself and let the public know whether you are a public or licensed member. Christina, please call the roll. Or, oh, I couldn't see you over there. Oh.
Good morning. Can you hear me? Okay, thank you. Rebecca Thies.
Present, public member.
Dr. Annette Walker.
Good morning, President, public member, her.
Kelly Ranasinga.
Present public member, pronouns he, him.
Susan Friedman.
Present public member.
Wendy Strack.
Present public member.
John Sovek.
LMFT member, home pronouns he, him, and I am here.
Oh. Rick Jones.
Chris Jones, present LP member, pronouns he, him.
Loretta Bailey.
Good morning, present public member.
For the record, Justin Huft, Eleanor Uribe, and Dr. Nicholas Boyd are absent. We have a quorum.
Thank you. We'll be now going into closed session, and depending on where we are in the agenda, just letting everyone know we're going to be looking to go to lunch at around 11:30. Morning. Welcome back to the November 21st, 2025 California Board of Behavioral Sciences meeting. My name is Wendy Strack, chairperson of the board. And before we convene, I'd like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing the board's laws. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. The Board of Behavioral Sciences will be holding this public meeting in person and via the WebEx platform. I will announce when we are accepting public comment on the various items. For each public comment period, we will first be accepting comments from the participants in the audience present in the room. Then the moderator will open the lines as appropriate so that the remote audience members can comment. Each commenter will have 2 minutes to comment. Moderator, would you please provide the audience instructions on how they may participate during the meeting at the appropriate times?
Absolutely. As stated before, people will be given 2 minutes to speak, and I'll give you a 15-second warning before your time expires. When the appropriate time comes, we are going to ask people to raise their hands, and you can do so by tapping that hand button at the bottom of the screen. Dial-in users will need to dial *3 to raise their hands. Back to you.
Great. Thank you, moderator. Moving on to item 16, introductions. Before the staff introduces themselves, I'd like to note that we have our new legal counsel. Over the past few years, we've had the pleasure of working with Sabina Knight, and we thank Sabina for the years of support and excellent guidance. But please join me in welcoming Shelley Ganaway, our new legal counsel. Shelley, we look forward to working with you and have enjoyed working with you so far. And now, board staff, would you like to introduce yourselves?
Yes, Steve Sodergren, the Executive Officer of the Board.
Marlon McManus, Assistant Executive Officer for the Board.
Christy Berger, Regulatory Manager for the board.
Roseanne Helms, Legislative Manager for the board.
That's it. Yeah, that's it.
Is that it? Okay.
Oh, Christina, they want you to enter.
Christina Kitamura, Administrative Analyst for the board.
And now is, are we good? All right. Now's the time for the public to introduce themselves if they would like. This is voluntary. Is there anyone in person that would like to introduce themselves?
Good morning. My name is Shanti Ezra, and I'm with the California Association of Marriage and Family Therapists.
You.
Good morning, Ben Caldwell, MFT. My company is High Pass Education. We are an approved CE provider as well as an exam prep provider. Thank you.
Seeing no others in person, moderator, are there any members of the public that would like to introduce themselves online?
There certainly are, and we're going to start with Sarah. We're sending you a request to unmute your microphone.
Good morning, Sarah Carrasco, Licensure and Compliance Specialist with William Jessup University. It's a pleasure to be here.
Next, Bindu. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Hello, good morning. Bindu Makamla, Policy Manager with the National Association of Social Workers, California chapter. Glad to be here.
All right. Dr. Jasmine, hold on. We're sending you a request to unmute your microphone.
Good morning, Dr. Jasmine Smith, Doctor of Social Work and LCSW with the NASW California chapter and Director of Capacity Building.
And those are all of our requests, Madam Chair.
Thank you. Moving on to item 17. Oh, okay, thank you. We need to take roll to reestablish quorum. So Christina, would you please take the roll?
Yes, we have a new board member that joined us, so we have to reestablish Rebecca Thies.
Morning, Rebecca Thies, public member, present. Thank you.
Dr. Annette Walker.
Good morning, present public member.
Kelly Ranasinga.
Good morning, Kelly Renisinger, public member.
Susan Friedman.
Good morning, Susan Friedman, public member.
Dr. Nicholas Boyd.
Good morning, LPCC member.
Wendy Strack.
Present, public member.
John Sovek.
Present, LMFT, pronouns he, him.
Christopher Jones.
Present, LEP member, pronouns he, him.
Lorez Bailey.
Present, public member.
We have a quorum.
Thank you. Now we move on to item 17, board chair report. Oh, that's me. Why didn't I look at Steve? Okay. Have some more coffee. All right. First, for board member attendance. This report shows the board member attendance for board meetings and committee meetings during the last year. And please let staff know if you believe there are any errors. As a reminder, attendance at the board and committee meetings is important. For future board meetings, you'll see in the materials a list of all the upcoming board meetings for 2026. These are proposed dates and may change in the future. After this meeting, please let staff know of any dates that you may have a conflict with. And then we have staff recognitions. We have a few staff members that we'd like to recognize for their years of service. Should have talked. Oh, they're not present. Okay. So is it?
Oh,
Kaylin?
Kaylin.
Okay. Kaylin Novi has served for 1 year and is currently part of the board's criminal conviction unit. Sabrina Guerra Anderson has served for 1 year and is currently part of the examination unit. Lisa Santolin has served 5 years and is currently part of the discipline and probation unit. Andrea Patrick has served for 15 years and is currently one of the licensing managers. So we just want to thank you all for your hard work and dedication to the board and consumer protection. Okay, and now we move on to the executive officer report.
Thank you. And I think what I'll do is, even though they're separate agenda items, we'll kind of go through, if it's okay, like we usually do, through the whole, all the items 18 through 26, I guess. And then we can ask for questions. Is that okay? Okay. As you notice, we kind of are moving around the agenda and kind of doing it a bit differently now. The idea is to kind of make each one of those kind of unit or areas within the operations of the board separate, so we can actually add more material to it as opposed to what we've been really presenting. So bear with us as we go through the kind of the evolution of this. So So for executive officer report, really what I'm like to do on this is just report on some of the activities that I've done in the past and some activities that the board members have done. So I recently, in August, I attended the ASWB Leadership Conference, and I am participating in the Regulatory and Standards Committee for ASWB. And what we do is we look at the Model Practice Act that they have and suggest amendments to that. So that weekend was that weekend allowed us to get together, various other states, about 8 other jurisdictions, including Canada, to talk about the Model Practice Act and make amendments. The other, I did participate in the AMFTRB annual meeting, and that was in September in Chicago. At that meeting, they really went over kind of similar, they went over the exam statistics and what they're doing currently with the exam, and talked about various other topics such as AI and psychedelic assisted therapy. We had some presentations from other states on what they're doing for that. The most interesting one, though, is Dr. Walker participated as a panelist in the Inland Empire, for some reason my notes don't, Inland Empire Health Plan appointments workshop. So she was asked by the governor's appointment office to participate in that. I don't know if you want to say anything about that.
Not too much. It was just a wonderful opportunity and honor to represent Governor Newsom's appointments Secretary Morgan Caraval and their team in assisting others in receiving information related to how to be an appointee, such as myself and the rest of the board members that were appointed by the Governor Newsom. So it was just a great opportunity. As people know that I do chair the Outreach and Education Committee, so it's like doing the work. So it's really actually nice to be out there doing the work of outreach and educating others about the work that we do here. So thank you, Steve, for noting this.
And sorry for putting you on the spot. Well, thank you. And then lastly, I did attend the ASWB annual meeting, and at that we covered the annual report for ASWB. They talked about exam updates. We do on that, it's kind of interesting that they do a regulatory case review and some of the federal cases that are out there that may affect our board and our licensees. So that's interesting. And then also ASWB is coming out with a new kind of PR campaign, and their logo will change. That'll be introduced next year, so stay tuned. Moving on to the budget update. Currently, we are budgeted for $14.63 million. Our projected revenue is at $23.7 million. Our expenditures are projected to be $15.6 million. And we're looking at an ending reserve at $34.2 million, which is 25.5 months. So we'll be hearing about our fee reduction later on. Personnel update, have a lot of promotions, one person leaving. In our examination and cashiering unit, Sabrina Guerrera Anderson was promoted to a staff service analyst. We have Pratishka Barrel. She was promoted from the cashiering unit and now works in our licensing unit, LCSW and LPCC licensure. And in our licensure, we have Arlisha Phillips was promoted to a staff service analyst position in the LMFT group. Registration unit, Michael Novang was also promoted up to a management service technician. And additionally, in the registration unit, we brought back Mary Cotto. She was a longtime board staff member. She got tired of retirement, wanted to work a little bit more. We needed the help, so she's back at it. So welcome, everyone. We did have a departure. Katrina Martinez departed from our consumer complaint unit. So we do have currently, I think it's 4 vacancies that we're really working on filling. That's in our examination and cashiering unit. That's for a managed services technician. We have a managed service technician in our licensing unit. Additionally, a staff service analyst limited term in our licensing unit. And the registration unit, we have an office technician position that we're currently conducting interviews for. So, and the consumer complaint, actually, we have an AGPA position that was Katrina Martinez's that we're needing to fill. Licensing report, currently, in the last quarter, the first quarter of this fiscal year, we brought in 5,925 new licensees and registrants. So our total population is around 157,000, and that's a 2% increase since the last quarter. Currently we have 16,000, around 16,000 supervisors that have sent in their certification. So that's looking good. Registration trends, we had 743 more applications were received in the registration unit than the last quarter. We're starting to look at deficient applications. That's something that it kind of gets missed sometimes in our workload. We definitely look at the applications received, but the deficiencies also have to be worked. So it's kind of almost, it's something that we need to look at. So we did highlight that in there. And for the registration unit, we had the deficiencies increased from last quarter by 41%. It seems alarming, but with the registration, really, it's the graduates sending in their paperwork, real quick, and we haven't received their transcripts or we haven't received their fingerprints yet. So it's not necessarily that the registrant did something wrong. It's just a matter of timing. So, and then we had AMFT applications were up by 49%, APCCs by 19%, but ASWs were down by 7%. It's it's the cyclical graduation type of period, so it's normal for this time of year. The licensing unit, clinical exam applications were down by 22%. Deficient applications rose slightly, and processing times on average for all three LMFT, LPCC, LCSW, and LEP averages out to 47 days, which is up from 45 days from last quarter. I forgot to mention that the registration unit is currently processing at around 26 days on average for the three registration types. So looking over year, we're doing pretty good on that. So I think we'll still make strides in trying to reduce that as we move forward. Some of the initiatives we continue in the licensing and registration unit is cross-training, making sure that we can pivot if we need help in a certain license type, we can pivot the staff over to help out in that unit. And the licensing group is developing supervisor and out-of-state licensing FAQs for the 2026 release. So some more information to get out there to applicants. For examinations, we administered 6,960 exams in the last quarter, which was a 9.3% increase from last quarter. And LPCC exam review, the OPS is doing every 5 years we do kind of an analysis of the exam, and OPS is currently working on LPCC kind of exam review on that. So the results are expected in February 2026. We conducted 11 workshops in the exam development, and ASWB had some changes to its accommodation, which was a good change. Before, the accommodations that were offered for the examinations would expire after a certain amount of time, and now they're open-ended. So it will carry through as long as the person is consistent in their exam process. So that was good. Also, Pearson View, our exam administrator, is upping its security a little bit more with using pilot security wanding. So I think that's really to detect electronics that might be, as you know, they can be anywhere now, glasses, clothes, whatnot. So just to kind of add a little bit security to that. Additionally, they have kind of loosened their requirements for IDs. Before, you had to have a signed ID, but now with a lot of electronic IDs out there, They're willing to accept electronic IDs, and you don't necessarily have to have a signed ID. So that is for the examination. Oh, one thing to mention too, it was a concern was brought up last time on the law and ethics exam pass rates for LPCC. We have been working with OPES to do an analysis of the test takers to see if there's anything we can identify that might be affecting that pass rate. I think it's going to be a really cool study to look at. It probably will generate some conversations, not just for the law and ethics, but just for the exams overall. So hopefully in February, we'll be able to report some data on that. As we move forward, enforcement report, consumer complaints, we received 795 consumer complaints, and that is a 50% increase over last year complaints. So we're looking at probably about 3,000 consumer complaints by the end of the year. We've been getting a lot. 260 of those were closed without investigations, and 429 closed after investigation. We referred 4 of those cases to the AG, and 5 citations were issued. So yes, our consumer complaints are increasing. Criminal convictions, we received 265 cases. 264 were assigned for investigation, and 230 were closed. And we referred 26 cases to the AG, including 12 accusations and 11 hearings. In probation, we have 14 new probationers, and we received 5 early termination petitions. And 2 petitions, also 2 petitions to vacate a default decision. We are reporting now, and as we move forward, I think we had a hiatus a little bit, but we do have continuing education results now. 25 citations were issued for failed CE audits. And I think we note in there that most of the failure rates that we see are for either non-response to our audit, or the actual licensee is missing 1 or 2, a few units of CE. It's rare that we see somebody that is completely missing all 36 CEs required. So we'll keep reporting on this. And the other thing that we are beginning to work on is the supervisor audits. We've been drafting the letters, looking at how to do that, pulling the actual data so that we can pinpoint who we're going to audit. So that audit's going to really talk about did they file the proper paperwork to become a actual supervisor, and then it'll carry from there and see what as it evolves, we might add on different types of audit processes. But I believe we will be able to report on that in February, so you get to see some actual data. And the outreach report, we had 12 virtual presentations that we gave. We were represented at the CAMP conference and the NASW lobby days. And we Marlon and crew just got back from the NASW California conference in Irvine. So I think that was pretty successful. It's always a great chance to meet applicants, future licensees, and to really talk to them about the board so they can have a better understanding that we're not that evil. I think we're there to help. So Consumer Information Center, the CIC, handled 4,000 calls, 67 seconds average wait time. We received around 43,000 emails. The highest, go figure, was in the registration unit for this last quarter, graduation. Lots of people had questions probably about their application. Social media, we keep gaining followers on Facebook and Instagram, but I think we kind of mentioned it a little bit in the outreach and education report. We're always kind of looking for ways to kind of expand past Facebook and Instagram, although it's a great way to connect. So we're pretty happy with that. In the administrative report, we received about 7,700 administration applications. And what I'm going to start looking at now, or at least presenting in the report, is how many of those are online. And those administrative apps can be anywhere from, it's like address changes, name changes, asking for an additional copy of your registration. And 95% of those, it looked like, were submitted online. So we want to keep moving our applications online. So that's what we'll kind of keep reporting so we can keep track of that. So you have an idea of what we're looking at there. The renewals, we had about 33,000 renewals that were submitted, and 63% of those were completed online. So that's an area where we have to kind of gain more online. It does help. The more we can do online, the better, kind of reduce the workload for our cashiering unit. Strategic planning, strategic plan update. The strategic plan is there for your review. The managers met with Solid Team a second time and went over some objectives and looked at the goals and looked at the environmental scan to see what we could do in the next few years to address some of the concerns that stakeholders had. And the next step is to come together as a board, and we're hoping we're might be doing that in February. I have to confirm that, but in our February board meeting. So we can finally come together and solidify and approve that report and move forward another 4 years. So we have a solid strategic plan. So kind of excited about that. That is my report. Thank you for listening. Sorry for going through all that.
Okay. Are there any questions from board members on items 18 to 26? Susan.
Steve, you mentioned at the very beginning that you went to a meeting where the various states told you what they were doing about. Sorry. You mentioned at the very beginning where you went to a meeting where various states told what they were doing about AI. Can you briefly summarize what you learned? Because every day I'm hearing that people are using AI for therapy, for medical care. I mean, it's getting very, very common.
Yeah, I mean, it's hard to give a real pinpointed overview other than we are all kind of looking at the legal and ethical uses and what as regulatory agencies our edict is or what we need to be doing on that. So it's really just, conversations of what other people are doing. Some of the states have passed laws in AI, kind of looking at what they've done, so there's a lot of conversations and it's very broad right now. But it's good to hear that so that we can kind of like pinpoint some ideas for regulations that may be going through, maybe looking at some regulations that we don't think are, appropriate. So, but yeah, it's kind of it would be hard to really report. Where are we?
Where are we on this?
We are, well, we kind of started the AI discussion with the AI, we had the AI listening session as a start to kind of get that conversation going. You'll be seeing, probably this year we're going to be having those conversations in committees. Not sure where we're going to go with that yet, but I think really the main priority is looking at our regulations that we currently have right now and what we need to update on that to make sure that at least the clinician understands their role in the proper use of AI. Some of the big things, I understand that there are a lot of concerns with chatbots and such. Unfortunately, our focus really has to be on the licensees right now. I think legislature, I believe, has, started kind of looking at the protection of the consumers. There's some legislation. I can't really speak to exactly what the legislation was, but they are looking at that. And there's one that just passed. You're talking about actually today.
Right. We will talk about a bill later that we passed that basically allows boards under DCA to take action of somebody representing themselves as a licensed practitioner. So that's a big first step. I imagine we'll see more broader legislation this year, starting in January, February, being introduced to address AI for the healthcare professions generally, as well. So stay tuned.
Yeah, so that's where we're at, looking first of all at our regulations and what we have and what we might have to really address there. And then additionally, Roseanne, she'll be busy coming up in the next, few months actually, bringing some of those legislative proposals to you for your approval or support. So we should see more.
I'm curious whether we have anything on our website where we advise the licensees what they should, if a client asks them, well, should I be using ChatGPT to find out X, Y, and Z? What we recommend that they say, or do we not do that?
We don't have anything right now. I mean, that has to go through the process of, first of all, we have to draft it and then kind of approval through the committees and stuff. It's not something that I honestly think it's something we probably will be discussing in outreach and education. And I think we've even mentioned it kind of in outreach and education before. So it is something that's on my radar. The definitely consumer brochure or something like that.
Thank you.
Sure.
Wanted to talk just a little bit about the complaints, the increase in complaints. So if I'm looking at the numbers, I mean, that's a big increase in complaints, but it seems like the majority of the complaints received, most of them get assigned for investigation, but the ones that are closed after the investigation, meaning that they're unfounded, correct? Okay, so that's looking at, it's close to like 80% of the cases that are closed. So I guess my question is, do we need to do a better job of informing the public about what constitutes a complaint so that we cut down on the number of, because if you're increasing the number of investigations by this much, I mean, that's really going to put a huge burden on your staff.
Oh, yeah.
So I'm just wondering, like, how to address that. That's question number one. Question number two, do you have any data or information on what the majority of these complaints are? Is there a pattern that we're seeing about what consumers are making complaints about?
So on the first part, just to clarify on the data there, it says those are many complaints we received, and then the closed can expand. That's not just for that quarter period. I mean, that's for, so it's the amount that are closed, it's a little less than 80%. I think it's lower than that, but
still majority.
Yeah. I mean, it's still, and I think what we're seeing is that data, and this is I want to say anecdotally, because I'd rather give you real numbers, but anecdotally, we have to log every complaint we receive has to be logged. So we are seeing an increase in people logging, the same complaint multiple times. That's one thing that we're looking at. Additionally, I think there's an increase because we did start the notice to consumer, and we think that is actually helping to increase our numbers. So people now know that they can come to us, which is a good thing. Which is a fantastic, it's great. But, some of the ones that are closed we get complaints about billing issues, and that's not really within our jurisdiction. I think we are seeing possibly an increase in now I can't think of the word. Boundary violations, I'm sorry, but not boundary violations with, not sexual boundary violations, but violations of therapists, operating outside of their therapy session and talking to their clients. So that's one thing. And I think what we're going to be doing is really concentrating and hopefully bringing to the board more stats about what the types of complaints are, so we can kind of delve into that. But yeah, you're right about, we had a side conversation about that. How can we actually put it out there of, here's what a complaint, here's what we can help you with and what types of complaints we can help you with. I mean, hopefully they would read something like, I don't know if it would help, but yeah, that would definitely something to the.
I mean, I haven't, personally I was going to file a complaint against Sovec over here, but
I would.
But I haven't really looked at that, the complaint process that we have on the website. I know that most other things on our website are fairly easy to navigate. So I'm curious about how much education is on the complaint portion of the website and whether or not that would help to reduce frivolous complaints, or that's not the right word, but if an uninformed, if someone's angry and they make a complaint, right? Because they're angry, but is it a violation? So just to support that process, because also, when the other thought too of thinking of the consumer, if they're unhappy with something that their provider is doing, then then it's not instead of filing a complaint, but the parameters of what it is that should be expected from a clinician, I think is important. So if they can see that and go, oh, there's nothing wrong with that, it's just a bad fit for me and I need to go find somebody else. So
Yeah.
to kind of cut down one on that anxiety, because I'm trying to put myself in the perspective of of a client and going, if I'm feeling that this isn't working to the point where I need to file a complaint with the Board of Behavioral Sciences, that's an additional level of stress and anxiety that's gonna increase whatever my presenting problem is. And so I'm just wondering if it's almost like when you have that, when you feel like you're sitting alone in a problem, and then you talk to someone else and they're dealing with the same thing, and you're like, oh, I'm not by myself on that. So I'm just wondering if that would be, if they would have kind of like a dual effect on both consumers and the the drag it's going to have on your staff and putting people through when they're making complaints that aren't going to go anywhere. Also, to cut down on that frustration, because if you're having people that are putting in multiple complaints for the same thing, they're like, I'm not being heard, right? So there needs, I would think that there would need to be some sort of, and I apologize, I had 2 cups of coffee this morning, so I'm little flying, but there would just need to be like some explanation to them, so they go, hey, you know what? Yeah, you're unhappy. I get it, but it's not a violation.
Yeah.
So just to think about.
No, and actually it was part of our, and it will be on like our strategic plan, I think too, is really, I think there's 2 ways to look at that. It's first of all, the consumer education, as in your consumer rights, and updating kind of the information we have so you can understand, when is it like a violation, or when is it maybe it's just you're unhappy with your, with the service you're provided, and what actions you can take. And additionally also is really putting out there, what is the license, what is the complaint process, is really beefing that up so people understand, when they really understanding that non-jurisdictional part too, because that gets really frustrating for an individual. And the more we can explain that, that might help out too. So definitely there, I honestly haven't looked at the complaint form in a while, but that's one thing though. I think it's definitely on my radar, the increased outreach or education, at least, as in what we have on our website for the enforcement process. Because it's once again, it's kind of that black hole for people. They submit and it's kind of, we definitely, the more information, the less anxiety, I think, for everybody, including us. I mean, that would help us. Everybody wins, so.
Just piggybacking on Dr. Jones's comments, in the actual consumer complaint thing, there isn't even an FAQ.
Okay.
And an FAQ might be a really great place to just start that process.
Yeah.
So just a consideration, because the consumer complaint section on here
Is it
is
just-
really, it's very structurally bare bones.
Okay.
Which I could see a purpose behind that, because you don't want to activate someone in a complaint cycle. But maybe an FAQ would be a consideration to address what
Something
Chris
real
is talking
simple like
about.
that, yeah.
Something as simple as that. Can I also continue on about deficiencies in applications that you noticed that large rise? I know you've been making a really concerted effort to get a lot of material out there. There's the 10 tips to smooth your licensure process. There's the video stuff. Is that getting a lot of views and clicks? And if not, maybe that's something we do in that Facebook, Instagram world, make sure that people know it's out there. Because you've created a lot of material already. So you'd think the reverse would be happening if you've made such an effort to put all of that material. But the thing about the way things move through our conscious right now is everything's really fast and quick. You may have put it once on Instagram or Facebook, but it gets moved out like within 30 seconds. So perhaps a continuous, like, take the 10 tips thing and break it down into 10 different things. Continually put it out there as your reminder. Here's the 10 tips guide. I think that might address it using materials you've already created.
Yeah.
'Cause you have a lot of stuff you've already
Yeah, me
done.
too.
So I think just make sure the applicants know that that material is out there.
Yeah. I know we do cycle some of the stuff, but yeah, is like pinpointing that we've talked about, I think maybe in the outreach stuff too, is some of those videos we did, clipping those down to bite-sized pieces and just keep recycling those because those talk a lot about the processing time too. Yeah, but I mean, application process.
Yeah.
So.
But it just to
Yeah.
me is like, wait, deficiencies are rising. At the same time, you've made this enormous effort to get this, how to do a better application process out.
And the clicks, that's what we're working on too, is that we talked with, it's just starting to look at the visits on the website, and that's Marlon's going to be working on the website redesign too. So I definitely want to get that metrics so we can start looking how to perfect that. So.
You mentioned about the budget. You said that brings up. Sorry, I only had one cup of coffee. You mentioned about the budget and you said that that would, of course, bring up the subject of fee reduction. Who decides that?
Who what? I'm sorry?
You talked about the budget and you said it brings up the subject of fee
Yeah.
reduction.
So the fee reduction is something that we're going to be talking about. It's a regulation. We'll be talking about that later today. That's the fee regulation that we're bringing on board because we have, what is it, over 2 years? We're coming up about 2 years worth of reserves, and so we have to reduce our fees. So we'll be talking about that later.
Are we going to be loaning any more money to the state?
No, I don't know, but who knows? So far it's 10 million loan, but I don't think, usually it's just a one-time loan that they take. I don't think there's going to be additional. So
Thank you.
but I have no idea. Okay.
Looks like that is all the board questions. We'll go out to our in-house audience participants. Do we have any comments on items 18 to 26?
Thank you. Good morning. Ben Caldwell, MFT. A couple of things. First of all, the AI listening session, Steve, that you referred to earlier, was really good, really valuable. Thank you for putting that together, and I hope that you do similar things in the future. As to exam stuff, the pass rate data that's presented in this report is once again troubling, both in the variability from one quarter to the next and in the sheer number of people who are not passing certain exams. When you have an exam with a pass rate below 50% for the quarter, as you do here with the ASWB clinical exam, you're telling the public and stakeholders that of the people who completed a graduate degree and 3,000 hours of supervised experience, more than half would be a danger to the public if allowed to practice independently. If that were true, that would be a truly scandalous failure of education and supervision. I don't think it's true, and honestly, I don't think that you think it's true either. But to whatever degree that you recognize that that can't be right, that part of your brain knows that you're not using a valid exam for licensure. Public safety is not well served by a licensing process that leaves out thousands of safe and effective practitioners, particularly when that process is known to disproportionately keep out practitioners of color. I'll comment on this again later as a request for a future agenda item, but there is significant peer-reviewed evidence of the lack of validity in the clinical exam process. These concerns aren't going away, and I hope you give them additional attention. Thank you.
Thank you. Do we have any other in-house audience members wishing to comment? Okay, seeing none, moderator, do we have any online comments for items 18 to 26.
WebEx, now is the time to raise a hand. You can do so by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few more seconds to see if we have a request online for public comment. Hold on, Dr. Smith. We're going to send you a request to unmute your microphone.
Good morning, everyone. So I just wanted to second what Ben was sharing about the pass rates and the challenges related to that. I know it's a discussion that has been shared a number of times in the board meeting, and I believe the most recent one we were talking about the disparities and the impact of that. So I am interested to hear his proposed additional agenda item to further the conversation on this.
Thank you. And that was our only request online.
Okay, thank you. That takes us to item 27, Department of Consumer Affairs report, which may include updates on DCA's administrative services, human resources, enforcement, information technology, communications and outreach, and legislative, regulatory, or policy matters. We have Shelley Jones, Assistant Deputy Director of DCA's Board and Bureau of Relations, who will be giving us an update on the Department of Consumer Affairs.
Good morning. As Wendy mentioned, my name is Shelley Jones, and I'm the Assistant Deputy Director with Board and Bureau Relations. Thank you for having me today to provide you the following information. For our DCA executive team update, we're very excited to announce 2 new members to the department's executive team. Governor Gavin Newsom appointed Lucy Saldivar as the Deputy Director for Board and Bureau Relations. Lucy previously served as Chief of Staff in the Office of Assemblymember Lisa Calderon since 2022 and Legislative Director from 2021 to 2022. She had held multiple roles in the Office of Assemblymember Jackie Irwin from 2017 to 2021, and she is also a member of the Hope Leadership Institute and the California Latino Capital Association Foundation. Secondly, I myself was appointed as the Assistant Deputy Director, and I bring 29 years of experience working with various boards. I have been with DCA since 2015, serving in several capacities with Board and Bureau Relations, as well as DCA's Strategic Organizational Leadership and Individual Development and Organizational Improvement Offices. Prior to joining DCA, I served in multiple roles at the Juvenile Parole Board with the California Department of Corrections. We are very excited to be serving you in our new roles with Board and Bureau Relations, and I know Lucy looks forward to meeting you all in the future. Finally, the sad part, after 36 years of dedicated service at the Department of Consumer Affairs, DCA Director Kimberly Kirkmeyer recently announced she will retire at the end of this year. Director Kirkmeyer began her career at DCA as a student assistant in 1989. She was appointed by Governor Newsom as DCA's director in 2019. And within her first 6 months on the job, she navigated severe wildfires and the start of the COVID-19 pandemic, transitioning the department's 3,500 employees to telework. Director Kirkmeyer would like me to extend a special thank you for the honor and opportunity to serve as your director for the past 6 years. She would also like me to thank you for your continued hard work and dedication to the department, the state, and the consumers of California. Your work is invaluable, impactful, and integral into DCA's mission of consumer protection, and she knows it will continue for years to come because of the extraordinary staff at DCA. On to less sad news, training. Sexual harassment prevention training, as you know, is mandated for completion within 30 days of your appointment to the board and every 2 years thereafter. On October 27th, we launched our new sexual harassment prevention training in the learning management system, which you all know as well as LMS. So the question is, do I need to take it? If you have completed the sexual harassment prevention training during 2024, 2025 in its prior version, the 2024, 2025 version. The new training will be automatically assigned to your LMS account 2 months before the 2-year mark from when you last took it. If you had not completed the sexual harassment training in the years 2024, 2025, the new version has already been assigned to your LMS account. It was done so on October 27th, and so you may log in and begin to take that training. Going forward, the compliance deadline will either be 2 years from the last completion date of the training or by December 27th for those who have not yet taken it, that will be taking it before the end of this year. Upon completion of the new sexual harassment prevention training, it will be automatically reassigned to your LMS account biennially, and that will be done 22 months from the last date you took it, which will give you a 60-day window to complete it again. If you have any questions or need assistance accessing the LMS, please reach out to Member Relations. Our email is memberrelations@dca.ca.gov. Additionally, our training unit developed unconscious bias training specifically for board members. This training is going to be added to your LMS accounts sometime by the end of this month, as well as incorporated into all onboarding when new board members are appointed. You can find your training records under the transcript section of your LMS account. And again, if you have any issues or challenges or need assistance accessing that, let us know. And lastly, the Our Promise campaign launched this month. Every year through the Our Promise California State Employees Charitable Campaign, state employees, including board members, have the opportunity to support the nonprofit causes they are passionate about through payroll giving or one-time donations. These contributions have a positive impact on our communities and is another way for DCA to show that it cares for California. The campaign runs through December 31st, and DCA will email out information to board members this month. In the meantime, you can give us a contact at Board and Bureau Relations if you'd like information on how you can give. And with that, thank you for letting me join you today, and I'll turn the floor back over to President Strack.
Thank you for being here. Do we have any questions from board members or staff? Seeing none.
I'd be amiss if I didn't put something out there for Kim Kirkmeyer has been an amazing director over the years, and her support has been fantastic. And I know she holds consumer protection to the highest, and she has been a complete asset to the department. So it is very sad to see her leave, but hopefully she'll, enjoy her retirement. So thank you, Kim.
Yes, thank you, Steve, for reminding us of that. Yeah, please pass along our congratulations on her retirement. And
I definitely will.
She will be missed, and really appreciate you being here today too. So thank you. Any others? Okay. Do we need to take public comment on this? No. Okay. Do we have any public comment from in-house audience? Oh, yes. Want to come up to oh, no. Okay. Do we have any comments online?
WebEx is taking public comment on the DCA update. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few more seconds to see if we have a request for public comment. Seeing no request, you wish to continue with the agenda?
Yes, thank you. And thank you, Shelley. Okay, we will be going to take a break before the next item, or?
Yeah.
Okay, I think we're going to take a quick 15-minute break before we move on to the next item. We will return at 10:32. Okay, good morning. We're back in session and moving on to item 28, an update on the Association of Marital and Family Therapy Board's national examination. Steve, can you provide us an update on that?
I can if I get my mic on there. Thank you. So in the August 2025 board meeting, we had the board approved the regulatory language that would authorize the use of Association of Marital and Family Therapy Regulatory Boards, Marital and Family Therapy National Exams. That is an acronym that is hopefully, let's go with AMFTRB. So AFTRB National Exams. So the board approved those regulation language and basically set me forward in implementing that language. And so with that in mind, what I'm presenting here is kind of a draft version of what we're looking at for the possible implementation, looking at a January 1st, 2027 date. And there's a couple of like 4 what I'm calling work streams that we have to concentrate on that are going to be key points in this whole process. The first one is the rulemaking process. So that is beginning. Christy, I believe you have the honor, thank you very much, of working on that. So the rulemaking is one of the main components of that. So the other one is the system development and readiness, and that is working with AMFTRB and PTC, which is PTC is Professional Testing Corporation, is the exam psychometrician for AMFTRB. And then there's another agency involved in this whole thing, which is Prometric. And Prometric is the actual administrator of the exam. So similar to us, we have OPES, AMFTRB has PTC. We contract with Pearson VUE to deliver our exam. AMFT contracts with Prometric, just to kind of give you an idea. Hopefully that makes sense. Back to system development. So we have to work with making sure that we really are looking for not a manual process to be able to deliver eligibilities and to accept scores from Prometric. So system development's important. I think I said this yesterday. One of the really key importance is the outreach and education. That's going to help out. There's the change this big. We want to make sure that we're very transparent as to what's going on, make sure that the actual candidates and people that may be in the actual examination stream right now understand what these changes mean for them and their process. So part of that is working with CAMP to help us get that word out there to people that are interested in becoming a licensed mental LMFT. The last thing is the examination transition. And the examination transition, what I mean by that is making sure there's going to be stop periods within the examination process. There's going to be a period where we have to have OPS stop making exams. So there's a lot of transition points to that. And I think part of that process really key is looking at, for us, is to really look at data and to see what we have out there with people that may be in the exam, kind of forecasting people that might be applying for an exam, and working to make sure that we mitigate, we mitigate any sort of issues that may occur for those people. So really looking closely at how we can make this a smooth transition. And like I said, part of the transition will be I can almost guarantee there will be a what I can quote, period of no testing whatsoever as we transition over. Kind of just go over the rulemaking process. So we have to draft the proposed regulatory language and put the notice of proposed regulatory action, the initial statement of reasons. That goes over to for DCA review. And really the big part of that is there's a 45-day comment period, which we will, which basically gives the public a chance to comment on the regulation to see if they either support it or ask for maybe possible changes to the regulatory language. And I'm hoping, I don't know, and look at Christy, maybe the February meeting, we might be looking at that again.
Yeah, I'm hoping we can, probably not February, actually, because I don't know that we'll be able to have our 45-day public comment
Okay.
period before then. I think that's doubtful.
Okay.
So it'll probably,
Sorry for putting you on the spot. Yeah, regulatorily, so
You'll
that's
definitely-
part of the process.
we'll
so.
definitely see any comments by May.
Okay. So we'll be working on that, and we're hoping to have everything approved by August 2025, which would then give us the ability to actually, it would change us to actually having to use the ASWB exam. I mean, whoa, AMFTRB exam. Whew. Sorry here, acronym crazy. I didn't have enough coffee this morning. Kind of going over the system development, like I said, it's about making sure that we can transfer eligibilities over, we can receive scores from Prometric, and we can monitor all the examination outcomes. They do, hopefully we've been able to work with most of our national vendors and have a system that is pretty not workload heavy to be able to do that. So hopefully we will have that in place. Like I said, outreach, what we're planning to do definitely is as much outreach as possible. That would start with FAQs. Definitely, sir, kind of locked into this WebEx type of platforms to have community engagement so that we can kind of get questions from licensees or people in the exam process or who are thinking about the exam. And lastly, just kind of going over the examination transition, confirming transition plan and timing. Definitely kind of went over this already, but the goal is to really what you're looking at here is kind of a draft proposal. I think in the next few months, December and January is really coming down to a really, really dialed in plan, basically a project plan for each of these. And I think really the first, trying to get that outreach and education out really soon. So sorry, kind of stumbling through that, but I'll open up for questions if that's okay. Yes.
Is there any estimation on how long the lag will be when the test changes over, about how long people will not be able to test?
So I believe when we did the ASWB transition, it was about a month. It was a month of no testing. So, and what we see in that, it's kind of interesting. Well, that's where I want to really estimate and try to estimate as best we can. As in, what we saw in that is people waited to take the exam, ASWB. So trying to estimate who's going to be wanting to take our exam, or who wants to take that the new AMFTRB exam. So part of that, I think we're looking at, I've been talking about, you can't, assisting CAMP, or maybe us doing with the assistant of CAMP, doing kind of a survey next year to see what kind of the feeling about how people are looking at that and how they're going to approach that. Do they want to? So a change like this also affects our processing too. So yeah, this one, I think I have a feeling more people want to take the AMFTRB, and so there will probably be a lag in our processing. That's wishful thinking maybe though. So sure.
Nick, LPCC member. So kind of a follow-up to Chris's question, if there is, during that delay period, and I guess from the experience with the ASWB, was there a backlog? Did it bottleneck at some point because people weren't testing during that period?
I don't know if I'm forgetting it because I don't want to remember it, but you know what? That's a good question. I can't recollect actually.
Yeah, and I think part of my question was randomly happened to look at the newsletter that was published on Facebook, and there were some complaints about delays for processing applications from folks there. So it just sparked my memory about that. And
Yeah.
so that would just be something I think we should think about, is what downstream effect that may have if we do pause during that transition period.
And I think I do remember part of the ASWB, what we did is depending on, I forget what like it was, but we did like, we would, as much as we could, encourage people either to hold off applying or actually apply earlier. So, and that's part of the outreach. When we see like what kind of, we have a good idea of what we think is going to happen, then, you know, this is going to be the dates. We understand, you know, maybe if you're thinking about this, wait till after this to apply for your, so kind of trying to work as much as we can to kind of get that communication out there. As we would really appreciate your assistance in either not applying right now or applying after this period or something. So
I can imagine how that's going to go over.
it's an ask. I mean, it's not, but I mean, the ASWB, I think it wasn't that bad. It was a pretty good transition. I mean, it wasn't that, painful for staff other than, yeah.
Yeah. And then my last question is, so this proposal is great. And it's built upon the premise that we've made a commitment, but we're not committed to the full transition to the AMFWRB exam. What would be the hard deadline that we would have to make a full commitment? Because I don't believe it's honest to show all of this without putting that in context. And I don't also believe it's fair to AMF, I always get the acronym messed up, for them to put in all this work without them truly knowing that if we are not making a full commitment to this or not.
That's a good question. That's a good question. We basically, I mean, when passing with the approval of the language, it's basically the board did give kind of the approval to move forward and ask me to kind of implement that. So I think until really,
But it was with the caveat that we could always back out.
You can back out.
Right. So I think it's important that we put that, we include that language, because we didn't say that we were 100% committed to this. We said we're going to move in this direction, but we could always pull away at any point in time.
Yeah.
I guess it's just important that we think about, as a board, when are we actually going to be firmly committed to this process, so that our stakeholders know, our consumers, so everybody's on the same page and aware of what we're actually doing.
Is there a point when the regulations might come back, when that would be the most appropriate time to do it, or sort of
Yes.
from a process standpoint?
So when the proposal goes out for 30-day notice, which it will within the next couple of months, people will comment, and then there will be comments on this one. It'll come back probably in May to the board. I mean, I think that's the point where if there's any major concerns raised, or it doesn't look like, we're ready to implement, that's kind of the last train out of the station. You have to by then. I mean, it's at this point, everybody's kind of making that preparation. So it should be something that's pretty severe. There's a major problem with the implementation. Somebody brings up a major concern that nobody's thought of, something like that. But May is sort of what I see as the drop dead. This is happening. But between then, if somebody brings up something earth shattering, then yeah, there's the room to reconsider. But once it goes for final, you review the comments, it goes back to OAL for final, that's kind of the point of no return.
Then it sounds like we wait for the May to be that decision point, unless we hear otherwise that we need to take some other action. We can do that at the February board meeting.
Yeah, and what we can do too is, I mean, we can still continue on with developing and stuff. I think the key components for having a drop dead commitment type of commitment, what we're looking at for that is really the transferring of the you know, the transferring of the questions that we currently have with OPES. I think for on the AMFTRB cycle would be, we would have to discuss that. So, but yeah, what I can do is looking at the plan, looking at kind of taking that into consideration, like a final commitment, what we can you know, what we can do without that commitment. And then, yeah.
Chair Strack?
Mhm.
Let me just weigh in on this. I do appreciate Dr. Boyd's comments and the responses, because I think, if I recall, maybe just a couple of years back when we really started digging deep, let me just back up and say, I do appreciate the present moment and where we are in this process. But I do recall myself making a comment and asking the question about how long have we been having this conversation? And I believe it was like a ridiculous number of years, more than a decade. So I appreciate you making the point that we really don't need to waffle and waver here. And to me, I appreciate the responses that were just said, but at the same time, I think it's imperative, like Chair Strack was saying, that we need to keep this in the face of our board agenda items right now. And we need to make sure that we are given ample opportunity to our stakeholders, our consumers, to be aware that we're not playing here. We're not going to try to continue this conversation another decade, but we really mean business here. Like, I love your choice of words. We're committed. Would you say we're committing but not committed? And so I don't even want that out there, you know, because again, that means we're wavering and we can always back out. The public and our consumers and our stakeholders have a right to know what are we really doing here. And so to me, it's responsibility of the board to make a decision. So again, I appreciate the leadership of our board chair and our EO, that we keep this present in the forefront of our agendas right now, so that we can give the support that we need to move the regulation forward and the process, and not just stop teetering with this conversation, whatever that's worth. I just think it's important for me to say that.
And I think what we can do is we can definitely bring this back in a different type of way in February. I brought this to the board as a update, so there's really not much discussion or actions or anything that we can take on that. But looking at, I can look to see how we can bring that back to the February board meeting to discuss.
It just came to my mind here. The why behind my comments are really for consumers. When we just had a conversation about pass rates and validity of tests and things like that. This moment is meaningful. This moment is imperative. The possible changes that we can put in place to move structures and barriers that aren't working for those that are having difficult, just in general, passing existing tests and exams out there. Is important to all of us. I know that it is. We've had this conversation, but we keep having the same conversation. And this particular conversation has been going on for decades. So stop it, enough. And so I'm a public member, Dr. Annette Walker, I'm a public member, and I just think it's important that I make those comments on behalf of the consumers and those that are struggling to pass this test, those that are very capable, well-educated, and desire an opportunity to move forward in their career advances without us having barriers in front of them that we have some say over, that is within our jurisdiction, testing and things like that. That's what we're here to, you know, to support them in being successful. And so I just wanted to make that comment. Thank you.
And adding on to Dr. Walker's point, and you can tell me if I've saddled the wrong horse, but one of the things I've noticed here in our rulemaking process, system development, outreach, examination, transition, it doesn't look like we have a goal to be coordinating with AMFTRB. Hopefully I did the right acronym for that one. about making sure the test is accurate for our population and the protection of our community, of our consumers. I don't see that in the goal set, us actually working with them to make sure that this test isn't just brought along, because we've been talking for a while about concerns about the testing system. We are in a place where we're putting up an enormous contract and a lot of trust in this organization, which also means we have the ability, and I think it should be part of our goal set to say, making sure that the exam is rated highly and as best we can for equity, diversity, inclusion, all of those pieces of the puzzle that we've been pushing back against for a while with all of these major testing systems. I don't see that on our goal plan, and I still believe it should be, because that is the one thing the board keeps coming back with concerns about. This board sitting here right now, multiple times, we've come back with that as one of our major concerns. So this is all very structural implementation of the goal set, but I believe there actually needs to be another part of that goal set that addresses some of these concerns. Did I ride the horse correctly, Dr. Walker?
No, I would also agree with Kelly Renessinger, public member. I'd agree with everything that has been said. I've been on board with this for quite some time. I think we just need to pull the trigger on it and get to the 45-day comment period and move it along. That being said, the letters provided by AAMFT and CAMFT were very interesting, particularly on page 28-12, where AMFT says, some researchers have reviewed both the national exam and the current clinical exam. They've concluded that the national exam is better than the California exam pertaining to the issue of racial bias. That's a pretty loaded statement. I'd like to know a little bit more about that so that, we could engage in some discussion as to whether or not, we can drill down on that concept and ensure that we are addressing the racial bias issue. So anyway, that's all I'd say. I would agree with what everyone has said so far.
Seeing no other comments from the board, do we have any comments or questions from our in-house audience members?
Good morning. My name is Shanti Ezra, and I'm with CAMFT. I want to start by thanking the board and staff for all of your work and planning, and continue to share that CAMFT remains strongly in favor of transitioning to the AMFT-RB national exam. We submitted a letter, which is attached to the materials in this item, that does detail many of the benefits of transitioning to the national exam, like license portability, federal opportunities, and access to care. And in our letter, we also shared some feedback on the national exam's content and scope, racial bias, and accessibility. We greatly appreciate AMFT-RB's willingness to continue to incorporate California-specific content into the exam. We do also feel confident in their ability to assess for bias and accommodate accessibility for California test takers. We're happy to continue to be of resource on each of these topics, and I know that AAMFT, is online today and can share more about some of the other states' experience with using the exam. So all that said, Steve, I wanted to thank you for sharing the planning overview and process for the transition. It's really important to us that we continue to work with the board, work with staff, and also work with AMFT-RB to ensure as smooth of a transition as possible, as we are well positioned and we are available to assist staff on each of the 4 major work streams, especially on the outreach and stakeholder communication and exam transition. I'll share that our team has already begun gathering inquiries from members on the transition to the exam. So we're happy to work with staff to identify areas where clarification and guidance will be most useful, assist with any surveys like the ones that Steve, you had mentioned, and then communicate those updates and timelines to MFT members.
15 seconds.
Thank you.
Good morning, Ben Caldwell, MFT. While I also continue to support this transition, the board and staff have raised a number of substantive concerns about the AMFT-RB exam today and in past meetings. And I know my friends at CAMPT have also raised concerns. I hope that as this process moves forward and these concerns are addressed, that happens with greater transparency, as this presents actually a pretty unique opportunity for the board to use its leverage to make the national MFT exam better. I'm wondering, Steve, are you able at this point to share anything that has changed or is going to be changed in the national MFT exam as a result of your discussions with AMFTRB?
I can't really, other than with the new job task analysis, there's a difference in the content and such, which is mirroring more of California, the way California has distributed. Beyond that, I mean, I don't know. I'd have to see what I could share.
I understand that. I know that some of the technical stuff does need to happen in closed session. That makes sense from an exam security perspective. But when it comes to some of the larger, I don't want to say philosophical because that makes it sound too abstract, but some of the larger constructs here where we're not talking about specific exam content or anything that would present a security concern around the exam itself. I do hope that both the board and AMFTRB err on the side of transparency, if nothing else, to improve faith in the process. Thank you.
Do we have any other public comments in the room? Seeing none, moderator, do we have any comments online?
WebEx is open for public comment. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand. And our first request is coming from Kathy Atkins. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Hi, this is Kathy Atkins from the California Association of Marriage and Family Therapists. I want to thank staff and the board for continuing to move this potential exam transition forward. I underscore some of the comments made by board members about dedication to a commitment to a forward transition. I would concur that waffling or moving forward in a, well, maybe manner is confusing to both the consumer and registrants. I think, I apologize, I forget which board member said it. I think there's always an opportunity as this transition moves forward, if there's a obvious concern or problem or pebble in the water that creates a consumer protection and or harm to registrants, CAMPT as well would be right there to cease forward movement if there was any kind of serious problem that could not be rectified. So I think CAMPT just asks for a clear message to registrants, stakeholders, consumers that, if you do choose to move forward, and we are hoping you do for the reasons
15 seconds.
That we are all committed together so we can educate the public and registrants. But again, we agree, we are right there with you with consumer safety, as well as ease of transition for the registrants. Thank you.
Thank you. Next, we have Roger Smith. Hold on just a moment, please. We are sending you a request to unmute your microphone.
Thank you very much. I'm Roger Smith, Chief Advocacy Officer with the American Association for Marriage and Family Therapy. Thank you for allowing me the opportunity to speak briefly to you today. And thank you again very much for the support of the board on this important initiative. AMFT strongly supports the adoption of the AMFTRB national exam as the exam for the state of California. Currently, the other 49 states do recognize the AMFTRB exam as the national exam for the marriage and family therapy profession. The MFTRB is very experienced in working with national exams. It's offered the first national exam in 1989 and is tens of thousands of individuals across the country have been able to successfully take this exam and improve competence to become a marriage and family therapist. The other major issue I want to address in addition to the comments I had, or to underscore those, is the issue of portability of the marriage and family therapy license. Adopting the exam will greatly enable MFTs to obtain a secondary license in another state where they can practice by telehealth means, or if they have to move for some reason or work in 2 states or live in California, another state, to be able to get licensed in that state. Currently, there are some states that do not recognize through licensure through portability for those who have taken only the California exam. And the adoption of the adoption of the AMFTRB national exam in California will allow those test takers who take that exam to be able to become more easily licensed in other states across the country for an additional license. Thank you again for the opportunity to provide these comments. I appreciate the opportunity to do so. Thank you very much.
And those are all of our requests online.
Thank you. John.
I want to point out something that keeps being said in this room, this idea of waffling, going back and forth and all this. I do not believe this board is actually waffling. I don't think we're going back and forth on this. We are at the juncture for an enormous change to be happening in a national testing system. Since 1989, they've been doing it a certain way. We are coming on board. California has some very unique needs in its population, in its both its consumers that we're protecting and also in the people who be taking the test. So I don't see this as waffling. I think of this of us saying, let's shake it open, let's examine it, let's look at this thing that's been done the same way for a long time and make sure that it's going to address our needs. In every request that's come before this board so far, we have been supportive and moving ahead on creating regulations, doing the work to set up the statutory information. That means when we do put the regs in place, that will move smoothly. We've been very supportive of that. So this word waffling, I really want to throw out of this conversation. I do not believe we've been doing that at all. And once again, we're just trying to look at all the facets of this that are open right now. The book is open to us. Let's point out the things where there are problems and challenges, see if change can at least be initiated. We're not going to get a perfect test on January 2027. We're not going to get a perfect experience. It's going to roll out. It's going to go through its growing period. But we're just saying, while the book is open, can we please shake it up, examine it, and make sure that we're at least initiating change that may have repercussions for a long time, not just for our California people, but also for the national test as a whole. I really want to push back against, we are not waffling.
Chair Strzok. Totally appreciate that, respectfully. I just think it's important to just put it in context. I don't think we're saying this board, that board, previous board, anything is waffling. So I'm not taking it personally. I did use the word, but it wasn't aimed pointedly at any particular board, past, present, or future. I think it's in a general statement of the conversation that's been going on for decades. So I appreciate what you're saying. I know we're doing some hard work here with the support of our stakeholders who have graciously commented that they're right there with us, supporting us. And if there is an obstacle or pebble in the road, that we're all here to address that together. So I think this has been a very collaborative process that we're rolling out here. So yeah, let's just keep that in mind. There we go.
something you wanted to say?
I got to say about informing the subcommittee. What do you think? Are you okay with talking about that? Can I mention that about the subcommittee maybe of 2 board members? So to assist me in better addressing the concerns of the board and kind of get a better idea of how we can proceed and you know, work with AMFTRB, there was a suggestion that I think it sounds might be good for me is to form a, I guess would be a advisory committee of 2 board members to kind of consult with me, and we can talk about what the board, you know, what we would want to see. So I don't know. Does that sound like it might be something that?
We can move forward with that, and board members, you can either indicate interest now on serving that, or you can email myself or Steve and let us know of interest. But if there's anybody who's particularly interested in it now.
We appreciate that. But I think it's been publicly addressed, what the changes that we would like to see, and that's to make the exam, it should be better, it should be improved, so that our questions are being answered in regards to what is currently lacking, where people are having difficulty passing the exam. We're addressing demographics, racial disparity, bias, and things like that. Again, let's not continue having the same conversation. So I don't think there's a need for me to say any more than what I've said right now, because it's been out there for a couple of years and I'm repeating myself. So it's on the record. So, but I appreciate the opportunity, and if anything else comes up, or if you need anything from any of us, you know, I'm sure the floor is open. You have very good relations with the board members, Steve, and we appreciate that. So I guess the floor is open to all, not just a couple, but to all.
I have kind of an alternative suggestion, because we kind of hashed out, it seems like we're doing well on the implementation side. John mentioned wanting more updates on the exam content side, which I think we're actually doing in terms of working with AMFTRB behind the scenes to make sure that the specific content is getting shared and included. And anytime you do a regulatory proposal, it's never set in stone until it is, right? Until it's finally approved. So my suggestion would be to, looking at the 4 points here that we're working on, provided and adding John's bullet point about the exam content and how those discussions are going, do a detailed update to the board in February to make sure that everything's running smoothly, and to board members can contribute to the discussion at that time, and then continue that work behind the scenes. And then in May, that will kind of be the point of no return, as it is for any reg. Whenever you get to the 45-day public comment period, it's either a go or adjust these things and bring it back to us. And that's part of the natural reg process. So I would say have the update at the February board meeting, and then we'll look at the comments in May, and we should see some pretty comfortable you can address any issues that come up then. But that's how I would suggest moving forward.
That's also a great suggestion. So Kelly, did you?
Do we need a motion for that, or is it just executive authority?
No, it's just it's no motion needed. And that's what we were going to bring, I mean, to February anyway, so.
Great.
And that's what I was asking for. I mean, like having an advisory council to say, this is what, you know, for the content and competency areas, or with those questions, this is what we're thinking about bringing, and be able to have that discussion with some board members, maybe to give, you know what, I think maybe we need to do this instead. So that's why I was kind of, for the February board meeting, it might help, so.
I like the idea of Dr. Annette Walker, public member, of keeping it open. Transparency is critical. So let's just make sure that we're keeping that in mind.
Any other comments? It sounds like. Well, and I think, Steve, you always have the ability to reach out to board members for their expertise between now and February if you want to consult with some of the license members, so maybe we don't need like an official advisory committee. You
Yeah,
you
no,
could
that's true.
reach out between now and February, and then we'll look for the next update in February.
Uh-huh.
Okay. Does that work for everybody? All right. Okay.
Very
Legal counsel, do we need to go back out for comments since we've had more discussion, or are we? Okay. Should go back out. Okay. Are there any comments from our in-house audience members?
Ben Caldwell, MFT. I just want to say I really appreciate the thoughtful approach being taken here and the attention that you're wanting to give now as you have the opportunity to, again, shape the national MFT exam. From a process perspective, I want to make sure that both concerns that are particular, specific to this exam and this immediate process are covered, and also that larger concerns about clinical exams and potential alternative pathways to licensure become part of that discussion. I don't know whether that means that that's the same agenda item with a broader discussion, or whether those are two separate agenda items. But I think if they are two separate agenda items, I think it would be really helpful to have them both in February. Thank you.
Hello, Shanti Ezrin with CAMPT again. Just wanted to thank board and staff once again for the commitment to transparency and the very thoughtful approach here, returning back and providing updates in the February meeting. So CAMPT is more than happy to help with all of the behind the scenes work between now and the February meeting.
Thank you. Seeing no other comments in the room, moderator, do we have any online comments? Just want to check back in with the moderator if we have any online comments.
My apologies. Now is the time for WebEx people to raise their hands. You can do so by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand. We will call on people in the order we have requests. We're going to take our first request is coming from Kathy Atkins. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Thank you, Kathy Atkins with CAMPT again. I want to show appreciation to the board for the forward move, what I hope is a forward movement. And I appreciate board member John's comments about various aspects, not only of testimony, but related to imperfect exam transitions, and just reiterating Shanti's commitment on behalf of CAMPT that we are dedicated to working with the BBS, AMFTRB, any stakeholders to ensure an educated, transparent, and least bumpy transition as possible. And, any way we can help, we absolutely want to be there for our registrants, for the BBS staff, and for the board to make this a positive, successful thing. So please know that we are here in any way, shape, or form to help in this transition. So thank you so much, everyone, for continuing to be so passionate and dedicated to MFTs as well as the consumer. Thank you.
Thank you. And that was our only online request for public comment.
Okay, thank you so much. Looks like we are ready to move on to item 29. Discussion and possible action regarding AB 2279 and AB 2581, consideration of requiring continuing education coursework in menopausal mental health and maternal mental health. And Roseanne, can you provide us with the overview?
Yes, thanks, Wendy. So we recently had two bills signed into law, AB 2270 signed in 2024, and AB 2581, also signed in 2024, that require the board to consider including a course in menopausal mental health and a course in maternal mental health, respectively, as part of its continuing education or CE requirements for licensees. Under current law, the board licensees must complete 36 hours of continuing education every 2 years, including 6 hours in law and ethics. The board permits CE coursework on a wide range of topics relevant to the practice of behavioral health, including both maternal and menopausal mental health, among many other topics. And licensees are, at the time, able to select CE courses that best align with their scope of practice and their client population. And so the board has historically recognized that there's a wide variety of topics that are important, but it has historically, because we tend to get these kinds of requests quite often, historically there's been some caution regarding mandated CE in specific topic areas for a couple of different reasons. First, the relevance, there has been past concerns about relevance that it varies by licensees, or somebody's practice might focus on one area, somebody else's practice might focus on a different area. So mandating CEs in a wide variety of areas may not be applicable to practitioners, and it could limit their ability to pursue CE that's more directly relevant to their practice, because CE courses do cost time and money. So it directs their resources more specifically. Also, there's the concern about precedent for future mandates. There's a wide variety of very valid and worthy topics out there. So it could set a precedent that encourages additional requests for CE-specific requirements. And there's only 36 hours, so the choice becomes either expanding it or having a lot of specific mandated topic areas. While many topics are valuable, that could reduce some flexibility. So the current CE framework already supports a wide variety of topics. The criteria now is that a licensee can take courses in a topic area that, as long as it's offered by a CE provider that's acceptable to the board, and it needs to be relevant to the scope of practice of the licensee's profession. And I would now like to welcome Elise Springer, who is the Policy and Advocacy Chair for Postpartum Support International, or PSI, California chapter. And she is going to present an overview of the importance of this topic and their requests. So Elise, welcome.
Thank you very much. Thank you, members of the board, for the opportunity to speak today. Can you hear me? About now. Okay, great. Thank you so much. And so my name is Elise Springer. I'm a licensed marriage and family therapist, perinatal mental health certified, and a volunteer board chair for the California chapter of Postpartum Support International's Policy and Advocacy Committee. I'm here on behalf of clinicians, advocates, parents, and community leaders across California who are urging the board to establish baseline perinatal mental health education. Of course, I will.
How about? Yeah, that's a great idea.
Yeah, I apologize, I couldn't hear.
How about now? Perfect. All right. I'm so glad to be here, and I'm so glad that you can hear me. I'm Elise Springer. I'm a licensed marriage and family therapist, perinatal mental health certified, and a volunteer board chair for the nonprofit California chapter of Postpartum Support International's Policy and Advocacy Committee. I'm here on behalf of clinicians, advocates, parents, and community leaders across California who are urging the board to establish baseline perinatal mental health education, both pre-degree and post-degree, for LMFTs, LPCCs, and LCSWs. All available data tells us that California is not adequately prepared for the mental health needs that arise during the perinatal period, preconception, pregnancy, birth, and the first year postpartum. While AB 2581 uses the language maternal mental health because that is how it is designated in the Knox-Keene Act, advocates use the term perinatal because this period affects the entire family, including those experiencing infertility, miscarriage, stillbirth, and infant loss, and adoptive parents as well. Perinatal mental health disorders are the most common complications of pregnancy and childbirth. 1 in 3 birthing parents in California experience symptoms, along with 1 in 10 fathers. The data on fathers has not been updated since 2007, and California does not track perinatal suicide in fathers or partners as it does in birthing parents. With more than 400,000 births annually in our state, tens of thousands of families experience perinatal mental health symptoms every year. This is a public health crisis. Perinatal mental health affects birthing people, fathers, partners, queer and trans parents, and it affects infants directly. Early development depends on caregiver well-being. Prenatal depression is linked to preterm birth and low birth weight. Early depression, early pregnancy anxiety increases the risk of preeclampsia. And in California, adverse perinatal outcomes are associated with increased risk of postpartum suicidal behavior. Mental health conditions remain a leading driver of pregnancy-related mortality. And critically, these outcomes are preventable when clinicians can recognize symptoms early and connect families to the right level of care. Families need clinicians who can distinguish normal adjustment from a perinatal mental health disorder. Inequities intensify this crisis. Black women in California face more delays, more gaps in care, and more structural barriers within health systems that shape their perinatal health. The California Department of Public Health highlights multiple inequities intersecting with pregnancy and postpartum well-being. Clinicians need training that addresses not only symptoms, but the structural and systemic conditions shaping perinatal mental health. Fathers and partners have significant needs that often go unrecognized. Paternal depression increases the risk of depression in children. Research describes fathers' experience of shame, invisibility, and isolation when they struggle. Studies show screening fathers in maternal and child health settings is feasible, and experts have called for routine screening. When clinicians lack training, these needs are missed, and families lose an essential source of support. Clinicians must also be able to differentiate between perinatal depression, anxiety, trauma responses, OCD, and postpartum psychosis. Postpartum psychosis affects approximately 1 in 2 per 1,000 births and typically emerges within the first days to weeks postpartum, often after families have already gone home. It has a distinct pattern, frequently including rapid shifts between depressive and manic features. Because early symptoms can resemble exhaustion or depression, providers without any basic perinatal training often miss early warning signs. Timely intervention saves lives. Clinicians trained in perinatal mental health know how to identify red flags, involve medical teams, and support families through crisis. Without training, early symptoms may be overlooked or misunderstood, placing both parent and infant and the family at significant risk. Infants are directly affected by parental mental health. Studies from the pandemic show how associations between perinatal mental health symptoms and neurodevelopmental outcomes at 24 months are impacted. Research on perinatal OCD shows how intrusive thoughts and compulsions can disrupt bonding and caregiving. And large studies, including the MOBA study of roughly 20,000 families, found prenatal depression in fathers increases boys' aggressive behaviors in toddlerhood. Perinatal mental health is early childhood mental health, but training must reflect this. California-specific research also shows that even well-resourced environments experience gaps. Studies have found that on-site mental health services improve access and reduce missed opportunities for intervention. Evaluations of past legislation, including the prior AB 2193, show statewide gaps in screening, referral, and treatment, but often because even when screens are positive, there are not enough clinicians who even know that perinatal mental health exists to refer to. Taken together, the evidence points to the same solution. California's behavioral health workforce needs foundational education in perinatal mental health. Consumers need this protection. The board already mandates training in human sexuality, substance use, suicide, and child abuse. These are essential, but none include perinatal mental health, despite mental health and substance use disorders being leading contributors to pregnancy-related morbidity and mortality. We respectfully ask the board to adopt a pre-degree curriculum requirement in perinatal mental health for all license types and a post-degree continuing education to ensure ongoing competency. Clinicians must be trained to differentiate typical postpartum adjustment from postpartum depression, postpartum anxiety, postpartum trauma, postpartum OCD, and postpartum psychosis, and to respond appropriately when symptoms signal elevated or emergency risk. The perinatal period shapes family well-being across generations, and when clinicians are trained, we prevent consumer crisis, reduce suffering, strengthen attachment, and support healthy development. When training is absent, preventable tragedies occur, and families face risks that could have been avoided. Today, the board has an opportunity to close a longstanding gap and align the behavioral health training with the realities of California families. You have the opportunity to increase consumer protection. California families are counting on you, as are generations of children. Thank you for your time and your leadership.
Thank you very much, Elise. And with that, I will turn it over to the board for discussion.
Thank you, Roseanne. I just kind of wanted to see if maybe you could speak to the process that's happening in Workforce Development Committee with the overall CE updates, because I think that's an important conversation here, that while the board is kind of going through a process about re-examining the CEs that we have, trying to figure out what's missing, or maybe what's already incorporated through other means. We're also reviewing degree requirements. We're going through that process. So I think there's a couple avenues where this could be integrated into one of those processes if it kind of fits into that process. So I was just wondering if you might be able to touch on that a little bit.
Sure. Yes. In the Workforce Development Committee, we are starting, it's a fairly large undertaking. We're starting with LMFT first, and we're doing a complete comprehensive review of the degree requirements. So what constitutes an LMFT degree? What's the core degree? What should that look like? What should the graduate level coursework that are required as part of the degree look like? Or if any of it can be remediated, what are the limits on remediation? And then all of the continuing education content that we require as like our requirements that can be CE, that can be done after the fact, like spousal and partner abuse, substance use disorders, things like that. So we are just getting started on that project. So at the January meeting, we're going to be talking about what does the core degree look like? And then at future meetings, we're going to look at the graduate level requirements and then the CE requirements. And then once we do that for MFT, then we're going to do that for LPCC, and then we're going to move on to LCSW. So we're going to be working on that for a while, but that is a project that is currently underway and we're actively working on.
Just seems like without that more, lacking that more comprehensive review that we're getting ready to do, seems like that process is probably the most advantageous place to kind of put in consideration of this particular issue and integrate it into that process so that we're considering it and it's a part of our thought process. We're going through those reviews rather than doing sort of a separate action now. That would be my thoughts, but I would look to my fellow board members for questions or comments.
I appreciate that information. In the meantime, what do we do to address, as was said, increase our consumer protection along these lines and address a longstanding gap in regards to what we just heard presented to us? I understand that what this undertaking that we're taking in your review, Roseanne, is necessary, it's strategic, it's good planning, but it also may cause a delay. So my question is, how long would this review take?
It's definitely a large project. It's gonna take quite a bit of time. It's not going to be something that's going to be ready to run for legislation either this coming year, obviously, or even probably the year after next. Is something that it's a major undertaking. I think the last time that we did an undertaking like this was a review and update of the LMFT education. I think we had a committee process. It was before I was here. It was like in 2007, 2008. I think they talked about it. They did a really thorough overview. It took a couple of years, and then they ran it as a bill, and then it had a delayed implementation. So it's not a quick, and we have 2 other license types to look at. So it is not a quick fix.
Right. I get it, and I understand that, and there's 2 sides of the coins here. And as a African-American, quote unquote, Black woman, understanding childbirth and the death rates and just how critical and important it is for us to address this matter, I understand that. But I guess, I don't want to get ahead of the quote unquote process, but I think we all would agree that there is a sense of urgency to listen to and address what we've heard today moving forward. So I don't know where we are with the stakeholders and where we are on the board's responsibilities in our jurisdiction and what we can do. If anyone is concerned about a timeline or anything like that, I just don't want it to just sweep it under the rug.
Any other board members want to jump in? Kelly?
I too am concerned. The attachments provided by the supporters of this legislation connote a feeling of exigency. And whereas, there are many things that are provided to the board asking for specific CE requirements. This one seems to have a great deal of relevance to all clinicians because, it's unlikely someone might, if they're in a different practice, encounter a person with X issue. In the course of their profession, they are very likely to encounter someone with perinatal issues based upon the prevalence rates inside the attachments. So I too am worried about what we can do, particularly because it also is very relevant to low-income and rural communities as well as tribal communities and minorities, what we could do in the meantime.
I mean, the options in the meantime is we could work towards outreach, possibly working with the powers that be to kind of come up with some outreach about that. That could be immediate. I mean, that's something that we don't have to. It wouldn't take that long to do something like that, and to support them in the cause while we're looking at, our regulations, our statutory requirements. That's a possibility.
Can you share just a little bit more about outreach? Maybe just give me short-term, long-term, what are you thinking?
I think what I mean by outreach is putting that, giving that space within giving that space within our ability to get out there on our website, social media, to honor the concerns and to, as much as we can get that word out there that this is a very important subject. And as a licensee, you might, this is something that you should really consider. And we're going to be working on, that's what I'm kind of alluding to.
Thank you, Steve.
We could encourage people to take CE in those areas because it is allowed. It's just it's not mandated. So
okay, we'll do Dr. Boyd and then Rebecca.
Yeah, I want to just first acknowledge that I recognize, the importance of this and the rationale as to why there's interest in trying to include something like this for continuing education. I also, want to acknowledge that there's a lot of other interests that I believe folks also believe are as important as this important issue to be included. And my reservation is that even though this is relatively broad, it doesn't touch every clinician in the same way that suicide requirements do and that telehealth requirements do. That applies to every single clinician, regardless of what their area of expertise are in. And so I think for me, I would be hesitant to make this a required CE given that we already have a pretty robust number of CEs required, and as somebody who were one of those 5 that just got audited, I could speak to that. That, you know, we do have a number of CEs, and I can speak from that same perspective, perhaps, that I, you know, have worked with less than a handful of folks that this has touched, and that's just my population. There's others that it'd probably be very relevant and very important. So I would just be probably less inclined for something like that. And I think it's important to acknowledge the importance of this, but also that making this a required CE would be, it may encourage others to not pursue other areas of their CE interest that would be more relevant to their clinical work.
First, I'd just like to thank the speaker for her presentation. Secondly, I think, Roseanne, this is a question for you. You did speak about the work you will be doing to go over CEs and other requirements. Our background materials say that 2 bills recently signed into law require the board to consider including a course in menopausal mental health and a course in maternal mental health as part of CE requirements. Can you speak a little bit more specifically about what board consideration means and perhaps what it
that was the language in the bill. So basically it means this, that the board is required to officially consider at a meeting, including those 2 things. It's kind of language that they would like it, but like the consideration. So that's what we're doing today.
Okay. Yeah, I think my question also was, is that work going to be happening at committee meetings?
It could, depending on what the board decides to do. This is the official consideration that we're required to do. And then the board can decide, you know, we want to do X, Y, and Z. And that would probably be fleshed out in committee, because usually like when we're doing detailed proposals, like we're doing with the MST education right now, I mean, we're doing a lot of work behind the scenes on that. And the board kind of sees the final product, but all of the like really details, like, what do you want, this wording or that wording, happens at the committee level.
Are there any other board comments or questions? If I maybe perhaps I'll offer motion, and then we can go to public comment just for consideration and just kind of hearing the board discussion, is that maybe we send this to the Workforce Development Committee for further consideration, integration into the existing CU or CE review process, and then also examining other ways that the board could act more quickly from a communications and education standpoint, or maybe that particular item goes to outreach and education.
Do you want it to go to workforce as integrated into the education requirement or the CE requirement? We're currently working on the education requirements.
Yeah, we just say.
What's that?
I'm saying, can we just say, just send it to the workforce committee for additional consideration? I think.
Yeah, and then.
Oh, no motion.
Okay, and then we can also maybe send the more immediate outreach education opportunities to that committee as well to see what can be done more immediately while we're considering this greater review process.
Yep.
Okay, and we don't.
No
Is
motion needed.
And we don't need a motion for that. Okay. With that, we'll go to public comments, unless board members have any other questions. We will take comments from in-house participants, and then we'll just sort of ask you all to come up one at a time. And as a reminder, everybody has 2 minutes to comment.
Good morning again. My name is Shanti Ezrin with CAMPT. I want to start by absolutely recognizing the importance of maternal and menopausal mental health and support improving access to qualified care. That said, we do agree with the reasons that staff presented, and for the same reasons is why we generally object to mandating specific CE course topics. New CE mandates are proposed almost on a yearly basis, and mandating CEs on a specific condition or population risks creating a series of narrower requirements that collectively reduce flexibility. We acknowledge the importance of these perinatal topics and do support efforts to encourage training and awareness in this area, but we believe each provider is ultimately in the best position to know what they need in terms of additional education and to pursue those in their CEs. Really appreciate Chair Strack's and Member Thies's comment about the committee's work with the education requirements, and we would look to the board and to staff's consideration of this topic as part of that review and development process. Thank you.
Good morning. Can you hear me? Yes. Can you hear me now? Great. Good morning. My name is Dr. Diana Barnes. I appreciate the opportunity to speak before the board. I'm a licensed marriage and family therapist, a perinatal mental health certified clinician, the past president of Postpartum Support International, and a member of the California chapter of Postpartum Support International. I'm also a parent. I've devoted a 30-year career to the field of women's reproductive mental health. In 1991, I received my graduate degree in marriage and family counseling. In 1992, while getting my hours towards licensure, I gave birth to my daughter, and for the next 3 years, I fought a life-threatening battle with postpartum depression. Despite my education and training as a therapist, I had never heard the word postpartum depression during my training, nor did I ever receive that diagnosis from any of the mental health professionals that I sought out for assessment and treatment. 3 years of struggle was far longer than I ever should have endured. Today, in the hands of someone who was clinically trained in perinatal mental illness, 3 years would be reduced to 3 months. In 2003, I was retained as a subject matter expert, where a woman was criminally charged after giving birth because I was one of the only therapists in California who could explain that her actions were the result of undiagnosed and untreated perinatal mental illness. In the last 23 years, I've been retained on approximately 100 criminal cases, half of them in the state of California. Too often, these women are sentenced to terms of incarceration from 25 years to life without parole. Research informs us that 40% of these women were seen by a mental health professional in the days to weeks leading up to the unthinkable.
15 seconds.
The unthinkable was avoidable if only that therapist had knowledge, training, and education. It is hard to imagine any therapist at some point in their career who will not come face to face with these issues. I respectfully urge the board to include perinatal mental health training
Time.
across pre and post-licensure requirements. I know it will save lives. Thank you.
Hello. Hi, my name is Daniela Bermudez, and I'm the co-chair of Postpartum Support International's California chapter, and LMFT, LPCC, and PMHC. And since the last 2 times I've been here to speak on this crucial importance of AB 2581, although I still see it's being connected to menopausal mental health, which is totally separate, I had another pregnancy and lost my daughter Penelope this past March, about halfway during my pregnancy. I had a medical emergency, and the hospital I was at was unable to perform a procedure to save my pregnancy, and I could not be medevaced or driven out due to a storm. I was left with no choice but to deliver my daughter by means of spontaneous termination, which left me with postpartum trauma, depression, and anxiety. I sought treatment from one of the largest mental health network providers in all of California. Not only did mental health providers not recognize what I was going through as postpartum, when seeking treatment, I was told we don't specialize in that. But you don't have to specialize in this as a topic, as it's relevant to all populations. Not to toot my own horn, but I'm probably one of the most equipped to navigate the system, not only because of my licenses and degrees, but having worked in managed healthcare system, prenatal departments, a part of the crisis continuum, and in suicidology. And I'm someone that has a lot of privilege working for me. And I had to fight and educate others at the most difficult time of my life to get the support I need and did not come in contact with one single provider that had training in perinatal mental health. I was sent in circles because of my presenting concern being the symptoms needed treatment due to a pregnancy loss. Their not knowing was a life or death situation for me. No one should have to go through this. The only therapists I knew who had the training to support me effectively and responsibly were mostly my own friends and colleagues, which is unethical. So it was impossible to get treatment from them. There needs to be a wider net of educated mental health professionals who know how to recognize and treat this issue and at least properly refer. I'm tired of having to
15
share my
seconds.
story. There are others who have done this years before me and others who are not alive to do it today. I'm also a graduate counseling professor who teaches human sexuality. There is not enough units or credits to even cover this amongst everything else. I urge the BBS to consider a pre-degree
Time.
curriculum requirement and mandate education requirements. Thank you.
Good morning. My name is Dr. Brenna Reason. I'm a licensed clinical social worker, perinatal mental health specialist with the PMHC and executive director of Be Mom Aware. This issue is personal for me. When I gave birth to my first child, I was already a licensed clinician. After abrupt cessation of milk production, I developed intense perinatal anxiety and disturbing intrusive thoughts. Because this experience was never discussed in my graduate education, supervision, or post-licensure training, I didn't recognize that what I was feeling was excessive. As a first-time parent, everything is new, including how you understand your own mind. It wasn't until I began working with new parents as a medical social worker, and pursuing competency in perinatal mental health that I saw myself in the literature. 4 years postpartum, still experiencing significant anxiety. Finally, I sought help. That delay harmed my daily functioning in ways that had been told were just normal for new parents. I'm here to say that they were not. Only after treatment did I begin to feel like myself again. I still live with the mental health effects of giving birth, but now I know I'm not alone, and it was not my fault. If I, as a well-educated licensed professional surrounded by other licensed professionals, did not see the signs and even had my symptoms downplayed, how likely is it that the average parent will receive the care that they need and deserve? In California, roughly 100,000 parents every year experience perinatal depression, and that's just one of the diagnoses. That's an annual estimated cost of $2.5 billion that's related to maternal mental health. Reviews of pregnancy-associated deaths show that mental health, including suicide, is a leading and often preventable cause of maternal mortality. Dr. Thomas and I conducted a qualitative study of 29 licensed
15
California
seconds.
therapists, which found that readiness to treat perinatal mental health conditions is largely self-developed, not system-supported. Clinicians describe their work as essential, but perinatal content remain nearly invisible in graduate education, licensure pathways, supervision, continuing education. Private certifications fill some gaps, but they're often time-intensive and increase inequities in care. Thank you.
My name is Alicia Middleman, LCSW, PMHC, and I'm also currently working on my doctorate in psychology and have completed all of my required coursework. This textbook with 2 single paragraphs is the total amount of education I received on perinatal mental health during my doctoral program and did not receive any during my MSW program. I have witnessed firsthand the damage that can be done by inadequately trained clinicians with this population. When I worked for Child Protective Services, I had a case with a baby who had a birth injury that was initially suspected to be a result of abuse. The mother's behavior raised red flags amongst hospital staff, particularly her apathetic nature toward her baby. After becoming trained in perinatal mental health, I realized that the mom in that case and many others I've worked with had PMH concerns. I wanted to highlight this case because the mother had to spend a year in mandated court reunification services with her baby out of the home when she only needed postpartum depression treatment. I did not know about PMH issues then, and now that I have been trained and understand this unique population, I can spend hours telling you about clients I have worked with who have untreated perinatal mental health concerns, including a mother who was diagnosed with schizophrenia after confiding in her husband that she had intrusive thoughts of hurting her baby. This mom was hospitalized for a month away from her baby and took antipsychotics for several years before being correctly diagnosed. We know that undiagnosed and untreated PMH concerns leads to adverse outcomes. Every single licensed clinician in the state needs to have a basic understanding of perinatal mental health
15
issues.
seconds.
This is a public health crisis and can be easily addressed through clinician education, and California has the opportunity to lead the way toward nationwide change. Thank you for this consideration.
Good morning. I hope it's still morning. My name is Robert Hickman. I'm a community advocate specializing in maternal mental health. I'm also a licensed marriage and family therapist. I began treating these conditions in the mid-1980s. In my experience, knowledge of these disorders, their etiologies, treatment options, and the complexity of the full impact on the mother, as well as on infant and family development, have expanded over the years. However, the lack of awareness, understanding, and experience by healthcare professionals, including mental health clinicians, was a major barrier back then, as it is now, to mothers getting the targeted support and treatment they need. I understand the reservations expressed by CAMF and the Board of Psychology about setting an unwanted precedent for future specialized mental health issues. However, I question the importance of that concern. Sometimes these issues are significant and focused consideration is important. For example, the mandate for training on HIV/AIDS began in the 1990s, I believe, and I never thought that I would see that issue in my practice. However, I did. The required training would have been helpful if it was available at the time. Now, why was it approved when such a small segment of the population was at risk? Because it was the right thing to do. You can agree that untreated perinatal mental
15
health
seconds.
conditions are a significant concern, as well as a racial, women's health, and reproductive rights issue. The disproportionate effects in communities of color, especially on Black mothers, their infants, and families, in my mind, perpetuates
Time.
and amplifies the impact of systemic racism present in the systems of care, including mental health. You are being asked to consider if the needs of the clinicians are more important than the supportive, therapeutic, and safety needs of the mothers. And my question is to you, what can the BBS do to promote an increase in awareness and competency? And why should this be approved? It's because it's the right thing to do. Voluntary training is not moving the needle. Please carefully consider what you can do. Did you hear me?
Hello, my name is Elizabeth Orrick. I'm a licensed marriage and family therapist in San Francisco, and I have over 75 hours of specialized perinatal mental health training. I'm also 7 months pregnant with my second child. I was already practicing as a therapist during my first pregnancy. I assumed I would be well prepared for what pregnancy and postpartum would mean psychologically, but I was not. Between graduate school and my prenatal care, I received 0 hours of education on perinatal mental health. I had to find specialized training on my own. Understanding risk and protective factors and knowing what symptoms warranted monitoring guided decisions that protected my mental health and my family's. But even without meeting diagnostic criteria, the perinatal period was still an acutely vulnerable time. The perinatal period is one of the highest risk windows for onset or recurrence of psychiatric illness for birthing people. Without foundational training, therapists miss clinically significant symptoms, mistake proportionate distress for pathology, and overlook warning signs that escalate into crisis. The result is undertreatment during heightened vulnerability, when untreated perinatal illness contributes to preventable morbidity and mortality. And we don't just risk one patient. When the birthing parent is depressed, partner depression rates can rise sharply. Mental health and substance abuse conditions account for nearly a quarter of pregnancy-related deaths in the United States. Suicide is one of the leading causes of death in the first year of postpartum. These deaths are overwhelmingly preventable. This is not a crisis of access alone. It is a crisis in the standards for clinical competency. Respectively, I don't
15
believe low
seconds.
exposure for some clinicians is an adequate response when consequences are this high and conditions are this common. I'm asking the board to formally require formal perinatal mental health education for all master's levels individual types. Thank you.
Thank you. Do we have any other in-house audience members wishing to speak? Okay, seeing none. Moderator, will you please see if there's any online comments?
Absolutely, we have several. Thank you for those who have put their hands up early. For those who have not, now is the time to get those hands up by tapping that hand button at the bottom of the screen. Dial-in users dial *3. And our first request is coming from Helena Vissing. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Hi, my name is Helena Wiesing. I'm a licensed psychologist, perinatal mental health certified, associate professor at the California Institute of Integral Studies. Over the last 10 years, public understanding of perinatal mental health has exploded. Parents today are extraordinarily informed, coming into therapy already aware of birth trauma and perinatal OCD, the risks of suicide, etc., and the serious disparities. These are no longer niche conversations, they are mainstream knowledge. Unfortunately, the training of licensed mental health providers has not kept pace with this cultural shift. Most graduate programs still offer little to no required education. Even though coursework in treatment of children or couples is required, even though many go on to not work with those populations. As a result, many new parents are encountering clinicians who either lack specialized knowledge and training or lack the basic knowledge of how and when to assess and refer out to specialists. The gap between the public's awareness and the profession's preparedness is widening, and the biggest concern with this gap is how it relates to suicide prevention, a core concern in perinatal mental health, and also mandated training for licensed mental health professionals, of course. And into this gap, a parallel ecosystem has emerged, unlicensed professionals, unlicensed individuals offering services that approximate, blur into, or directly claim to be mental health treatment. And although well-intentioned, they are often practicing far outside the bounds of safety. When vulnerable new parents cannot find appropriately trained licensed providers, they become easy targets for unregulated and often harmful alternatives. This is
15
deeply
seconds.
concerning. We need licensed clinicians to meet the moment. We need standardized training, and we need regulatory bodies to recognize that perinatal mental health is not optional, it is foundational. Thank you for your time.
Thank you. Next, we're going to hear from Kiki Carlson. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Good morning. Can you hear me?
Yes, go ahead, please.
Great. Thank you so much. Good morning. Thank you for the opportunity to comment. My name is Kiki Kalkstein, and I am here representing the Policy Center for Maternal Mental Health, where I am a policy consultant. The Policy Center works to close gaps in maternal mental health care. I am also a two-time survivor of postpartum depression, anxiety, and bipolar disorder, and a certified peer specialist. I experienced severe postpartum depression after my first daughter was born, and when I got pregnant with my second, I had open lines of communication with my OBGYN, therapist, and PCP, and we did everything to prepare for the possibility of the depression returning. Then the unexpected happened. She was born at 32 weeks while we were on vacation visiting family. After a month-long NICU stay and living temporarily on the other side of the country, my postpartum depression came back. My prescribing doctor at the time had no special training in perinatal mental health. She increased the dosage of my antidepressant twice in too short of a time frame, and I experienced a medication-induced manic episode. I then needed a week-long stay in the psychiatric ward at a local hospital and additional care through a partial hospitalization program and an intensive outpatient program. My daughter was only 3.5 months old. My story didn't need to unfold the way that it did. And if I had been seeing a provider with specialized training, my experience may have looked incredibly different. California families continue to face barriers to timely perinatal mental health care. Strengthening licensure requirements ensures every clinician enters practice with essential training in the perinatal period.
15 seconds.
I respectfully urge the board to include perinatal mental health training across pre and post licensure requirements to strengthen California's behavioral health workforce and improve care for families across the state. Thank you.
Thank you. Next, we're going to hear from Dr. Jasmine Smith. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Good afternoon, everyone. As the NASW California chapter is in support of this mandate, and I wanted to share a couple of reasons why. As the subject matter expert earlier shared, this is not only an issue for women, but also the family and the children who are impacted. There is an estimated cost of $2.25 billion related to untreated maternal depression in California alone. And with the BBS responsibility to consumer protection, it is our understanding that this is something that would be necessary and required. I know that there were also some discussions about suicide and substance use, which this does intersect with. I do want to share that maternal suicide is the leading cause of maternal mortality in the United States. So because we are able to identify the high risk of suicide, because we're able to identify challenges with chemical dependency, and with the awareness that it intersects with maternal mental health, perinatal mental health, there is even more of an urge of a reason why we need to consider that. I also want to note that as it relates to individuals of lower SES, I want to thank Dr. Walker for her note on how this impacts individuals from diverse communities. I would like to add that specifically for Black women, there were 2 individuals who were impacted by this, causing the Kira Johnson Act and also April Valentine, 2 California Black women who unfortunately were killed as a result of the inappropriate support and services that they received. Specifically for Kira Johnson, she was healthy, already a mother of another child, and because they were not able to see and understand her needs, again, she is no longer
15
here with
seconds.
us. Lastly, there are an organization, Maternal Mental Health Now, and UCLA Prevention Center of Excellence, who offers 2 free CEUs, one on what to know for providers, which is 6 continuing education units, and also 201 how to help, again,
Time.
for providers. So I would urge that we consider that because we have a good number of CEUs that we can use, and it doesn't mean by requiring this that providers interested in other specialties and needs are unable to do that. We have 36 and renewal 18 in the first, and there's plenty of opportunities to continue that growth with that many requirements.
Thank you. Next, we're going to hear from Sonia Castadina. I apologize for the last name. Please correct me.
Hello, it's Sonia Castaneda Cudney.
Thank you.
Of
Go ahead,
course,
please.
thank you. Good afternoon. My name is Sonia Castaneda Cudney. I'm a doctoral candidate in policy planning and development at USC and a mental health policy researcher in Los Angeles, California. I'm speaking to the board today as a mom of 3 beautiful children and as a survivor of perinatal mood and anxiety disorders. I'm fortunate to be here speaking to you today. I almost wasn't. Following the traumatic emergency birth of my twin daughters in 2018 and the loss of my infant daughter, Lucia, in 2019, due to her health condition during my pregnancy, my mental health understandably deteriorated. As a person who works in mental health policy, I knew that something was wrong and I sought help, but as clear as my perinatal mental health symptoms were and as high as I scored on my screeners, as many mental health providers as I saw, I didn't receive appropriate follow-up or care. On the surface, I was functioning, but internally there was an alarm bell blaring in my mind that only I could hear. I couldn't calm my mind. I imagined that I was the cause of all of my family's problems. I found myself thinking that my family would be better off without me. One night, when I was so hopeless, I was crumpled on the floor after the kids were asleep. I made a Hail Mary to my husband. Thankfully, he heard me, and he sought out help. The person he found wasn't aware of perinatal mental health disorders, but she was a good listener, and she wanted to help. Somehow, at the same time, for work, I was assigned to attend a conference hosted by the Policy Center for Maternal Mental Health now, which was previously 2020 Mom. That conference, not my therapist, was my introduction to perinatal mental health disorders and my first step in my pathway to recovery. I finally had insight that I could share with my therapist, and she and I
15
worked
seconds.
together to find a specialist who could support me. I'm lucky. Other families are not. Liliana Carrillo, Danielle Johnson, they're not lucky. Their families aren't lucky. I now work to help others to not have to go through what I did. My story needing help
Time.
is not unique. In California, as we said, 1 out of every 3 pregnancies are affected by perinatal mental health disorders. Please include perinatal mental health as a mandated learning component for your mental health providers. You will save lives.
Thank you. Next, we have Dr. Megan Spence. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Hi, I'm Dr. Megan Spence. I'm a licensed clinical psychologist and perinatal mental health certified. I'm also the mother of a 2020 child who was born in the COVID pandemic and the California wildfire. I'd like to just highlight again that this is not a women's health issue. This is a family health issue that affects spouses, it affects multiple generations of a family, and it affects children. So really, anybody who's working with anybody will likely come across pregnancy and postpartum at some point, to those who don't think they see this in their practice. I'd like to share a story about somebody who was successful in treatment and the power of getting the care that they need. One of my favorite patients became quite ill postpartum and was stockpiling medication with the intention to kill herself. Luckily, she told her husband took her to an ER. The ER sent her to IOP, and she eventually found me. This patient got the care she needed. She got medications, she got therapy, and thankfully she's still alive today with a beautiful child who's thriving. But if she hadn't been in the care of people who were adequately assessing what was going on, who she could learn to trust, the trauma from her childhood that was activated in her traumatic birth likely would have killed her. And she's not alone. We've heard so many stories today, and we know that this issue is life or death for so many women and disproportionately affecting particular communities that are especially vulnerable. We have to act. Why is it that we mandate suicide prevention training, but we wouldn't mandate maternal mental health care
15
training?
seconds.
Equally as important, and again, affecting all levels of the family and also multiple generations. Please consider this and mandate training today.
Thank you. Next, we're going to call on Lindsay Wang. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Good afternoon. My name is Lindsay Wang. I am a family nurse practitioner, and I also have my perinatal mental health certification. I work with the underserved and marginalized community in the San Fernando Valley in Los Angeles as a primary care provider. But I see firsthand the need for clinicians to be more trained in perinatal mental health disorders. As a survivor, I know the importance of support. I also experienced postpartum depression, postpartum anxiety, and postpartum OCD. And it was the support of clinicians who knew about perinatal mental health disorders that saved me. And I see my community that I work with needing this and needing clinicians that know how to speak about perinatal mental health disorders. As a nurse practitioner, we are required to do pharmacological hours and geriatric hours for our CMEs. I don't understand how this cannot be a requirement for clinicians. Um, I think this is something that California is really trying to change. And I think that this change in mandate is the right path. Thank you.
Thank you. Next, we're calling on Kendi Fay. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Hello, good afternoon. Can you hear me?
Yes, go ahead, please.
Okay, thank you. Thank you for the opportunity to speak. My name is Kendi Fay. My pronouns are she, they, aya. I'm a perinatal trauma therapist, a CAMFT member, doula, educator, and researcher with over 15 years experience supporting families around the world. I'm also here as a mother and survivor of traumatic birth, which ultimately led me here today. I want to thank the survivors who spoke courageously and to those whose work in reproductive justice have shaped my knowledge. We are in the midst of an ongoing crisis of preventable perinatal and infant mortality, disproportionately affecting Black and Indigenous birthing people nationwide. In California specifically, this crisis stands to worsen as perinatal care deserts continue to close around the state. For survivors, birth is often a traumatic event leading to long-term trauma symptoms due to lack of access to care and a shortage of trained staff. Perinatal mental health, specifically the prevalence of birth trauma, which is my area of expertise, affects everybody, from the birthing person to their partners, providers, and their children. Meaning, as long as we are working with clients who were born, this education is important. Our field has long accepted that early childhood experiences have profound impacts on the mental health outcomes across the lifespan. There's also ample evidence showing that this starts in utero. In utero means the health and wellness for a pregnant person is foundational for the mental health outcomes we spend our careers treating: trauma, anxiety, depression, attachment, neurodivergence, and family systems dynamics. Given this reality, we have an ethical duty to include perinatal mental health training in our education and licensure pathways. CAMF's own ethics require competence,
15
avoidance of
seconds.
harm, cultural humility, and active awareness of the ways implicit bias shapes care. Without perinatal mental health training, clinicians risk misdiagnosis, re-traumatization, and perpetuating disparities that already cost lives. Perinatal mental health cannot remain optional.
Time. Thank you. Hold on just a moment. Next, we're calling on Simal Ozan Imrak. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Hi, thank you so much for this opportunity. I'm Shumal Ozan Irmak. I'm a mom of two who experience perinatal mental health challenges. I'm also a neuroscientist working in this field, so I'm a public member to this committee. And I'm a volunteer at PSI Central as well as PSI California. So through my own work and volunteering, I meet with tens of parents every week. And there is one thing common across all of them, which was also true for me as well: timely access to trained providers. Now, I believe we all realize that, let's say a pregnant mom contacts a provider, it's already a few months late than she needed to. At that point, her needs are severe and stakes are extremely high. We need to make sure that that person that she meets, that provider, has the basic foundational knowledge to guide her to safety and to support her appropriately. This doesn't mean that everyone needs to be specialized in perinatal mental health. We understand that some clients will be handed to other providers, but we really need to make sure that when someone is connected to a provider, they will be safe and supported until the next level of care. So considering that, in California, likely 1 in 10 households are going through some part of their perinatal journey, whether it is pregnancy, postpartum, loss, or fertility challenges, I really can't see that this doesn't apply to all providers across the board. So I strongly recommend the board to reconsider
15
their
seconds.
position on the training requirements. This will save lives. Thank you.
Thank you. Next, we're calling on Shanna Averbach. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Hi, I'm Shauna Averbach, LMFT and PMHC. I've been focused on perinatal mental health for the last 11 years in private practice. People have bravely and beautifully shared their personal stories today, and while I do have my own postpartum depression and anxiety nightmare, and I do attribute my swift recovery to my extensive self-selected education and practice in perinatal mental health, I want to share about a family member instead for context. In 1948, at the age of 19, my grandmother gave birth to my mom, her first child. They were soon separated, and my mom was raised by her aunt for the first 2 months of her life while my grandmother was hospitalized with severe mental illness. We never got many details about this time, as regardless of any stigma related to it, my grandmother also had holes in her memory due to the practice of electroconvulsive therapy, commonplace at that time. These hospitalizations happened throughout my mom's life, and they just understood that she had depression. She was never fully and accurately treated. 60 years later, at the age of 82, shortly before she died, after one of many hospital-induced psychotic episodes, an educated clinician finally reviewed her entire chart, piecing together my grandmother's diagnostic story, especially looking at that first postpartum episode. She was dumbfounded that this person had been told they had unipolar depression and were treated as such. Likely she had bipolar depression with psychotic episodes. The ripple effects of this untreated mental illness, the attachment wounds, the developmental trauma, they still exist in my body, my mother's, and will likely impact my children. Hard as I may try to change that.
15 seconds.
And we're merely one cluster of many. Both mental health education and treatment has grown so much since then, and perinatal mental health touches all of our clients in ways already discussed. I believe in the future we will look back and wonder how we did not provide basic perinatal mental health education to all clinicians. Thank you for considering adding this to requirements.
Thank you. Next, we have Marina Fuenzalada. My apologies for all names I've mispronounced so far. Please feel free to correct me.
Thank you. Good afternoon. My name is Maria Fuenzalida. I'm a bilingual LCSW, a certified perinatal mental health provider, a board member at PSI California's California chapter, and a former Child Protective Services investigator of 13 years in Los Angeles County. I'm here today to strongly urge this board to mandate basic perinatal mental health training for all clinicians in California. During my time as a dependency investigator, I worked with families experiencing extreme stress, trauma, and loss, and yet many of the parents I worked with did not have the ability to even choose their own mental health provider. They relied on whoever was available, whoever spoke their language, whoever was assigned, whoever would even see them for free. And this is precisely a time when, for many of them, perinatal informed care can make the difference between stabilization or removal, between reunification, or long-term system involvement. California's child welfare system serves over 700,000 children each year, and on any given day, more than 175,000 children are in contact with the system. Most importantly, over 50% of children who enter foster care are 5 or younger, meaning the majority of families involved in the child welfare system are parenting infants and toddlers during the high-risk perinatal period. Additionally, I'd like you to acknowledge the unique needs of pregnant and parenting foster youth, many of whom carry trauma histories that are complex and have very limited support themselves. Perinatal-informed clinicians can provide the compassionate care that these young parents need to break cycles of involvement, support healthy attachment, and create safer, more stable family systems. A statewide mandate would also help destigmatize perinatal mental health, especially for families from underserved communities where mental health conditions are often misunderstood, sensationalized, or minimized. When every clinician,
15
regardless
seconds.
of their background, has accurate training, we reduce bias, increase trust, and ensure all families receive equitable treatment. Perinatal mental health training is not just a clinical education. It is a child safety intervention, a family preservation tool, and a bias-reducing, stigma-dismantling public health strategy. You have the power to ensure that every clinician in California across every system has the basic knowledge needed to recognize, respond to, and appropriately support perinatal mental health. Thank you.
Thank you. Next, we have Jessica Ford. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Hello, everyone. My name is Jessica Ford. I'm a full spectrum doula, a survivor, a perinatal mental health trained provider, and an MFT intern, currently in my third year of my master's program at Pepperdine University. I'm here because I strongly believe that perinatal mental health disorders should be a required part of graduate level training for all future clinicians. In my role as a doula, I've witnessed firsthand how perinatal mental health disorders impact not only the birthing person, but the entire family system, partners, siblings, extended relatives, and the long-term well-being of the parent-child bond. These are not niche issues. These are some of the most common complications of pregnancy and postpartum, yet they remain dangerously under-recognized. What has been most surprising as a student, and honestly alarming, is realizing how limited and non-existent perinatal mental health education is in higher education programs that are training our future therapists. In my coursework, I've had professors who are unfamiliar with perinatal mental health disorders during classroom discussions. I've participated in case consultations with fellow MFT interns actively working with postpartum clients, and I've seen misdiagnosis simply because perinatal mental health is not considered a standard part of clinical education. As a doula, I'm often the first person to identify these symptoms, not the clinician or the provider with a license. That is a profound disservice to new parents. Support professionals should not be expected to carry the primary responsibility for recognizing these clinical concerns simply because therapists are often not taught to look for them. Perinatal mental health is not a niche, it is foundational.
15 seconds.
Every therapist regarding of specialty will encounter clients who are pregnant, postpartum, parenting, or carrying unaddressed perinatal trauma. For the health of families, for the safety of parents, and for the integrity of the profession, perinatal mental health must be a requirement for all higher level education programs. Thank you.
Thank you. Next, we have Kathy Atkins. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Thank you, everyone. My name is Kathy Atkins, and I am with CAMFT. I start by saying that I empathize with those who have testified today and the passion they bring, as I myself have had to live, or when I was pregnant, I had to live much of my turbulent pregnancy in a hospital with postpartum mental health issues following me home post-pregnancy. So my empathy is there. With that said, CAMFT is opposed to the proposed additional CEs being presented today. Over the 2 decades I have been with CAMFT, we have frequently and routinely seen CE mandates presented to the boards, with those proposals being forwarded by individuals, groups, and advocates with equally compelling areas of treatment and client work that they too were fighting for. CAMFT does not believe CE mandates are the solution. CAMFT is opposed to taking away healthcare providers' agency in determining where they need additional education and experience and increased competency. There are many treatments, modalities, patient care areas that aren't specifically called out through CEs that one can argue have imperfect coverage in the master's curriculum. Areas that directly and indirectly cross therapist caseload that one could argue should have CE mandates. This remediation to deficiencies needs to be resolved through an intentional and researched assessment and resulting improvement in the master's education, not through a patchwork of CEs. CAMFT supports an assessment of the master's education requirements to see where there are areas of deficit, including maternal mental health. And if it's determined that there is indeed a deficiency, we would absolutely support curriculum improvements in these areas outlined today. We do not believe the concerns articulated today will be resolved through CEs, but instead need to be ingrained into the education of the healthcare providers as they begin their careers.
15
As I
seconds.
noted, we oppose the proposal of additional CEs to those regulated by the BBS, but if the board feels more conversation is needed, we would suggest delegating this proposal to the appropriate committee to better delve into the subject area, assessments, testimony provided, and proposal before you today. Thank you so much.
Thank you. Next, we have a caller from area code 408. We're going to send you a request to unmute your microphone. When prompted, you'll be required to dial *6. I'm going to send you that prompt now. Caller from area code 408, are you with us?
Yes. Hi. Can you hear
Go
me?
ahead, please. Yes.
Okay, great. Hi, this is Dr. Lisa Weninger. I'm a white cisgender uh, doctorate holder. I hold a lot of privilege. I am in favor of anything that uses government systems to protect the vulnerable. The issue at hand affects all genders, but particularly female identified. And I am also conflicted. We are currently living in an increasingly misogynist and racist culture where the government is being weaponized against vulnerable populations. Just recently, this week, female-dominated professions are being declassified so that they will not qualify as professionals in order to qualify for student loans, as just one side example. This training would have significant impact on our profession in positive ways. And I am also simultaneously against more regulations that add barriers to licensure, just like we heard from Kathy Atkins just now. However, I am very, again, conflicted because if we don't require CEs, many of our colleagues, I'm an LPCC, I forgot to mention that, many of our colleagues do not seek out the training that would help them not cause harm. I still personally in my practice and professionally encounter many colleagues who are not following just the basic laws of how teletherapy needs to be practiced in California as an example. And I know many, many counselors that I encounter who do not come from a racially informed lens, for example, a white counselor working across cultures. This happens systemically in California within our professions. However, how is this more important than gender affirming care, protecting trans clients, neurodivergent affirming care
15
for
seconds.
those holding any kind of BIPOC identity? I'm wondering if there's a way to make this like a menu of options where CEs are mandated in some culturally specific ways, and the board says you must choose from this selection to support a variety of different populations, and then there's more
Time.
choice. There's impact on the counseling compact by adding more regulations in California that pushes us further away from being able to join that, and it adds cost to the licensure process. I hope all of these factors are considered before decisions are made.
Thank you. Next, we're going to hear from Troy Gabrielson. Hold on just a moment, please. We're sending you a request to unmute your microphone.
Good afternoon. I'm a licensed clinical social worker in private practice. I work with fathers and other parents with young children. The research indicates that an estimated 20% of mothers and 10% of fathers will develop a mood or anxiety disorder during pregnancy or the postpartum period. That represents thousands of people each year who will need adequate assessment and care. At the same time, too few providers have training in this crucial topic. If we're responsible for reporting suspected child abuse and neglect, then why would we not also have a responsibility to the parents of those children? The research is clear that if parents are suffering emotionally, there are serious risks to their child or children. It's essential for providers to have basic familiarity with perinatal mental health. Before becoming certified in perinatal mental health, I worked with a client who, with his wife, learned of a planned pregnancy during the course of our work together. My client's wife soon began experiencing concerning behavioral symptoms, like sharing significant regret about the pregnancy, wishing the baby was not coming, and appearing very irritable over months. The client was very concerned and felt alone, and I had no framework for assessing or supporting his concerns. If I had, I would have strongly recommended she be screened for perinatal mood and anxiety disorders, and I would have had at least a basic model for helping my client. How different would his experience in my care at that most vulnerable time have been if I could have better met his needs? Let my being here as a therapist and a father indicate that this is not just an issue for mothers. I implore the board to add a perinatal mental health training requirement for all registrants and licensees regulated by the board. Thank you very much for your consideration.
Thank you. And potentially our final comment from Cassie Manjikian. Hold on just a moment, please. We're going to send you a request to unmute your microphone.
Thank you and good morning. My name is Cassie Manjikian. I'm a postpartum psychosis survivor, a board member with Maternal Mental Health Now, and the founding director of the California Perinatal Wellness Alliance with over 20 partner organizations and 600 advocates statewide. I really appreciate today's discussion about CE requirements, the board's desire to be systematic, and concerns about setting precedent. But I want to respectfully underscore that perinatal mental health is not one topic among many. It's the most common complication of pregnancy, the leading contributor to maternal mortality, including suicide, and a whole family issue that every clinician will encounter, whether they specialize in this area or not. Yet, clinicians graduate with no required perinatal mental health training, leaving them without basic skills to recognize risk, accurately screen, or support early intervention. In 2016, I experienced postpartum psychosis, a condition I'd never heard of, despite having a public health degree from UCLA, private insurance, and every advantage. I saw multiple licensed clinicians, and none were trained to recognize my risk factors. After a long labor, I went home 4 hours after birth and couldn't sleep for 5 days. The hallucinations felt like being trapped in hell. I was admitted to a hospital that had a maternal mental health department, but my care was siloed and traumatic. I was transferred to a psych ward where I was shoved in a padded room, bound in leather restraints, and sedated. The next day, I was sent home without any follow-up care. My recovery took 7 years, cost over $30,000 out of pocket, and nearly cost me my life. And I'm one of the lucky ones. As we've heard, Black women are more than 4 times more likely to die from pregnancy-related causes.
15
For
seconds.
this reason, I respectfully urge the board to adopt evidence-based perinatal mental health training as a required CEU topic across relevant license types, because this is a foundational competency, not a specialty. Thank you for your leadership and for considering this critical step.
Thank you. And we have a new potential last request from Bindu Mukamala. Hold on just a moment, please. We're going to send you a request to unmute your microphone.
Hello, good afternoon. Bindu Mukamala, Policy Manager with the NASW California chapter. I just wanted to echo Dr. Smith's comments earlier. The NASW California strongly expresses our support for requiring continuing education in maternal mental health and menopausal mental health for licensed clinical social workers. Maternal mental health conditions often go unrecognized, and California faces a significant and solvable perinatal mental health crisis. And to echo some of the speakers before me, according to the California Department of Public Health, about 1 in 5 women or 100,000 women annually experience pregnancy-related depression during their pregnancy or their first year following childbirth. These challenges affect maternal well-being, infant development, and long-term family outcomes. And many individuals also experience emotional and cognitive changes during menopause that impact daily functioning. California already requires focused CE training when it benefits public safety and well-being, such as child abuse reporting, human sexuality, and substance use disorders. And we believe maternal and menopausal mental health deserve the same level of attention. For these reasons, NASWCA supports adding these CE requirements so social workers can better serve and meet the needs of the communities they serve. Thank you for your consideration.
Thank you. And hold on just a moment. Are we accepting repeat comments?
No, sorry.
All right. Thank you. Those are all of our requests for public comment.
Thank you. Just gonna take a look back to the board and to staff if there are any additional comments on this item. Dr. Walker.
Yes, thank you, Chair Struck. Given the public comments online and in person, I think it warrants us to circle back on helping everyone to gain a better understanding of our board's consideration of what's on, what we're discussing, and how CEs factor into that, and how the work that we're doing on looking at education requirements and curriculum. I think we need to circle back and explain or just help us get a deeper understanding of kind of where the board is on this.
And I'm trying to.
Another explanation of the education requirement, what project?
Again, the board is considering this matter of mandatory CE requirement, correct?
Correct.
This is on the table.
That's on the agenda today. Yes.
Yeah, this is on the agenda. So In light of what we just heard from the public, online and in person, I am requesting and asking that we circle back and help them or remind them and give them a deeper understanding of the process, where we are in considering taking this into consideration versus the work that you're doing in reviewing curriculum and education requirements, and also the CE possibility of this coming into fruition.
So I mean, I think where we left it before was looking at the consideration, continuing the consideration onto the different outreach committees, first of all, to look at possibly supporting, outreach for this, and then also to the workforce committee to put it into the discussion of the CE and education requirements. I think that's where
You're answering my question.
Oh, okay.
Thank you very much.
Okay.
Just
yeah.
circling back, this is what we've said previously, but we've had some extensive discussion on this matter. For those that may have joined the call later and didn't hear that in the beginning, I think it was worth us circling back and letting them know what we're doing, where we are,
That makes sense now.
presently and future. Thank you
Okay.
very much.
Okay, seeing no other comments, I think staff has their direction and their next steps, and just want to thank everybody for joining us today and for sharing your stories and highlighting for us the importance of this board's consideration on this topic. So we appreciate you traveling up to be with us today. I think at this point, it's a good idea for a lunch break for us. Are we at a 60-minute break? Yeah.
It has to be at least 45 minutes.
Well, probably 60 minutes
Okay.
would be good.
Okay.
So everybody has enough time to get something. So the board will come back at 1:40. Good afternoon. Thank you and welcome back to the Board of Behavioral Sciences meeting. We are going to head to item 30, discussion and possible action regarding amendments to the board statutes related to advertising. Roseanne.
Thank you, Wendy. So this is really more of an update, but it's a big project, and we talked about it a little over a year ago, and we have some new board members, and we've graduated to step 2 in the process. So I wanted to give an update, kind of a little bit of background for people who might not have been here, and then talk about where we're going next now that we've made our first level of progress. So at the September 2024 meeting, the board approved a 4-step process to clarify and modernize our statutes and regulations related to advertising and client disclosure. And the order in which these changes were going to be made has to be done very carefully, because it basically involves putting some things that are in statute and regulations, and some things that are in regulations, moving those to statute and vice versa, and then making everything consistent across license types. So it has to happen in a very specific order. So it's not something that can be done all at once. So we are almost finished with step 1, the amending the advertising regulations. I'm happy to report that those are at OAL for final review and hopefully approval. We should know by about mid-December whether or not they're going to approve those. So that's the first step, and that moves some things into the regulations to make certain disclosure requirements for associates consistent across all the associate types, because previously we kind of had some requirements for certain types of associates and other requirements for others. So we want to make everything consistent. So now we're moving on to step 2, which is statute changes for associate trainees and interns. And there's certain sections in our law that discuss both the client disclosure requirements. Hey, I'm an associate, I'm working under supervision, and then also their advertising requirements. This is what they have to say in their advertising. We're looking to run some changes to make those consistent across all license types as well. So that is what we're moving on to as step 2. So you will see that there is some approved language in attachment 2. We already have board approval for it, but I wanted to bring it back today to remind everybody. So that's step 2. And then after we do that, which is going to be this coming legislative season, then the third and final step will be amend regulation section 1880, which is basically a really simple, we're going to do a non-substantive legislative change to strike the information in section 880 because it will then be already in statute because we're moving it there now. So the additional step, amend advertising definitions in statute. There were some inconsistent definitions of advertising in each practice act that we made consistent. That was kind of a standalone thing, and we did that this year via SB 775. So those new consistent definitions will become effective on January 1, 2026. So that's where we are and where we are going. I don't want to bore you too much with the details unless you want to have all of the details of the changes that were, because they were already approved by the board, but they are an attachment 2. And essentially there's a set of statutes for each license type that we're making to the disclosure and advertising requirements in statute for associates. And there's one for trainees and interns. So you can see that language that was approved by the board. And there's also a chart, a set of charts in the materials that show basically what the differing requirements are. And you'll see that the requirements are all over the place, and then how we're making it consistent across license types. So no action is needed unless you have any new concerns or wish to make additional changes, but that is the update.
Okay, do we have any questions from board members on this item? Seeing none. Do we have any questions from our in-house participants?
Got it. Okay. Thank you so much, Shanti Edrin with CAMF. No questions. Roseanne, just thank you for circling back to this and going through, or at least listing the different proposed amendments here to clean up some of the different sections in statute and making the requirements consistent across all the licensure types. So no concerns. Thank you very much.
Any other? All right. Moderator, do we have any comments online?
All right, WebEx, now is the time to raise those hands if you wish to make a comment. You can do so by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few more seconds to see if we have a request for public comment. Seeing no request, do you wish to continue with the agenda?
Yes, thank you. Just looking back at the board, if there's any last chance for comments or questions on this one. Oh, Dr. Boyd.
Yeah, I just, Nick Boyd, LPCC member. I recognize this is not the place for it, and that there's still work being done to look at education and other requirements. But I do think it's worth noting here, because this is about advertisement, that for PCC trainees and for social work interns, using the language that they're unlicensed, that they're a trainee performing services that are that he or she is unlicensed and under supervision is a little bit misleading, because, and I recognize it's just the language and that's how the statute is written, but it's implying that they're being supervised by somebody that perhaps has the skills and the qualifications and the competency to be providing supervision, unlike what the MFTs have, which is appropriate and how it should be because they're gaining accrual hours. It's very specifically about a licensed supervisor. So I just wanted to make that note, because I do believe as a consumer, they're probably not going to understand the difference if it's not explicit about what that actually means to be under supervision of who and for what, and what are those qualifications of the supervisor providing that type of supervision. And I think that's very, very, very important to think about.
Great. Seeing no other comments. Roseanne, do you want to respond to that?
Yeah, and I will just respond to that. I definitely understand your concern. And yes, part of the education review discussion is going to be looking at, some of the requirements for supervision and for practicum. So there will definitely be an opportunity to address some of those concerns there.
And you do not need an action from us on this.
I do not, unless I'm not hearing any changes. We already have a motion from September 2024, so I can move the item without a motion today.
Okay, great. Right, then we will move on to item 31, discussion and possible action regarding proposed amendments to the Business and Professions Code to be included in an omnibus bill. And Roseanne.
Yes, so every year the board staff reviews the statutes to look for minor technical, mostly non-substantive change amendments to see if there's anything that needs to be changed and that we can place in an omnibus bill that the legislature via the Senate Business and Professions Committee run every year. They typically call it their committee bill. And these are items that can't be of any substance, they can't have any opposition. Basically, that's the rule of thumb criteria. So usually it's smaller things that aren't really an item that can stand alone as its own bill, basically. So we've identified 3 different areas of some things that need updating. And so I'm going to go over each of those and then I'll open it up to questions. So the first thing is a minor change to the supervision via video conferencing language. And you'll see that in attachment A. Current law requires supervisors to assess the appropriateness of using supervision via video conferencing within 60 days, regardless of whether video conferencing is actually used. So that's not necessary if supervision is conducted exclusively in person. So we just want to add some clarifying language that the assessment of appropriateness of supervision via video conferencing is only required if they're actually using supervision via video conferencing. So that's the first change. The second change is at the very end of the legislative session this year, the Senate Business and Professions Committee decided to move some language in statute or some requirements in statute from the general Business and Professions Code to our specific practice acts. And it was a pretty technical change. It was just some cleanup they were doing, but it basically affected the human sexuality training requirement for our board and the child, elder, and dependent adult abuse assessment. Those 2 sections were section 25 and 28 respectively, and they were in the law. They were grouped together. They grouped together our board and the Board of Psychology. They'd been like that for a very long time. I'm not really sure why, but because they grouped together our board and the Board of Psychology, it was pretty difficult to amend those sections because basically 2 sets of boards have to agree on the exact requirements. So they were in need of some updating, and now that they've been moved into our practice act and sort of decoupled from Board of Psychology, we have the opportunity to do that. So I'm proposing some minor changes. I will say that these are not comprehensive. We are going to be looking at human sexuality and child, elder, and dependent adult abuse content via the Workforce Development Committee because we're doing that to start LMFT education review. So we're going to be looking more specific at what these sections actually say in terms of the content required, but there are a few things that can be changed now. So those things are that we are proposing to clarify that the required 7-hour course in child abuse assessment and reporting must be California specific. It is already required to be California specific, but what the law currently says is that it needs to contain course coverage in the Child Abuse and Neglect Reporting Act, or CANRA. CANRA is specific to California, but a lot of people, unless you have really technical knowledge of the law, don't understand that and they kind of gloss over it. So we want to say that it's California specific content. The second thing that we want to change is we want to remove the provision allowing the course in child abuse assessment to be taken from a professional association or a local county or state department of health or mental health. Those are not necessarily accredited or approved CE providers. They might be, but they aren't necessarily. For all other courses, the board only accepts coursework from an accredited or approved educational institution or a board recognized CE provider. So that's sort of some outdated language from before we put that requirement in. So we'd like to make that specific to CE providers or accredited agencies, consistent with all of our other course requirements, to make sure that they have that extra level of review there. And then finally, we want to eliminate there's an exception in the child and elder abuse coursework requirement that's very old that allows somebody to opt out of that coursework by demonstrating that it's not relevant to their current practice. Now, to my knowledge, at least recently, we haven't had anybody request to do this, but it's an important enough topic. Abuse can affect individuals across a wide range of setting, and a therapist's current practice does not necessarily reflect their future practice needs. And so ensuring all licensees receive training in child abuse assessment and elder abuse assessment supports public protection. So those are the three changes there. And then finally, the third change, it's very basic. Because the legislature at the end of the session decided to move those two code sections into the board's basically practice acts, there were a lot of references throughout the law that referenced their old code section number. So we need to update what the new sections are. So we're proposing to do that. So at its October 24th meeting, the Policy and Advocacy Committee reviewed the first two proposed items that I discussed. The third item, the code section renumbering, is a new item not previously discussed at P&A. But for the first two, the P&A committee recommended that the board consider it as legislation. So here we are, and I'll open it up for discussion.
Thank you. Do we have any questions for Roseanne on the board? Like your presentations are very thorough. Do we have any comments from our in-house audience? Oh, I'm sorry, Kelly, go ahead.
It's okay, I was just going to make the motion, but I think you have to do public comment.
Oh, no, we should probably make the motion first. Otherwise, we have to go back out.
I would move that staff make any proposed changes, any non-substantive changes pursue as a legislative proposal.
Do we have a second?
Second. Dr. Walker, public member.
And now we go to in-house public comment.
Hello, Shanti Ezrin again with CAMPT. No questions and no concerns with any of the proposed amendments. Thank you.
Moderator, do we have any comments online?
Thank you for the opportunity. My apologies. WebEx, now is the time to raise your hand by tapping the hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few seconds to see if we have a request for public comment. Seeing no request, do you wish to continue with the motion?
Yes, we'll go ahead and continue with the motion. Seeing no other comments, Christina, would you take the roll, please?
Larez Bailey.
Yes.
Christopher Jones.
Yes.
John Sobek.
Yes.
Wendy Strack.
Yes.
Dr. Nicholas Boyd.
Yes.
Susan Friedman.
Yes.
Kelly Ranasinga.
Yes.
Dr. Annette Walker.
Yes.
Rebecca Thies.
Yes.
Motion carries.
Thank you. Moving on to item 32. Discussion and consideration of comments received during the 45-day comment period for the fee reduction regulations and the discussion and consideration of adoption of amendments to the fee regulation language. And Rachel, this is you.
Good afternoon. My name is Rachel Lanzoni. I am the budget analyst for the board here to present on those proposed fee reductions. I also have with me
Christy Shields, Regulations Counsel for the board.
and online we have Matt Nishimini, Senior Fiscal Advisor from the Budget Office to answer any technical questions that may come up. So at the May 2025 board meeting, the board approved the proposed regulatory text changes pertaining to its fee reductions. The proposed regulatory action was noticed to the public on September 19th, 2025, and the 45-day public comment period ended on November 3rd, 2025. During the public comment period, the board received a request for a hearing. A public hearing was held November 6th, 2025, and the public comment period was extended to noon of that day. The original board-approved language was provided in Attachment A for the board's consideration. The board received 32 written comments and 1 oral comment as summarized in the memo. The written comments are provided in their entirety in Attachments B through GG. The transcript of the public hearing is including the single oral comment is provided in Attachment HH for the board's review. Staff's recommended responses to all comments are also provided to the memo. In the memo, this agenda item has 2 parts. In Part A, board staff and legal counsel have summarized and recommended proposed responses to all written and oral public comments received. Of the 32 written public comments received, the majority expressed support for the proposed regulations. Few requested clarifications or offered differing suggestions on the duration of the proposed fee reductions. Some commenters included statements which did not address the rulemaking process, and we recommend the board not respond to those statements. Of the written comments, board staff would like to draw the board's attention specifically to comments which expressed something other than support. These comments are very briefly summarized as follows. From Attachment D, on September 19th, 2025, the board received a written comment by Reina Moreno, LMFT. Commenter's stance on the issue was not clear to the board, but they requested a public hearing. The hearing was held, and we did not receive further comment from this commenter. From Attachment G, also on September 19th, 2025, the board received a written comment by Vicky Kwan, LCSW. Commenter requested the rationale for why the LCSW initial clinical exam fees were left out of the proposal. The board's recommended response explains that the LCSW clinical exam is not board administered, and therefore the board is not authorized to change that fee. From Attachment L, on September 24th, 2025, the board received a written comment by Heather McFarland, ACSW. Commenters stated their support for the proposal. They also wrote that they hoped for a public hearing. That hearing was held, and we did not receive further comment from this commenter. Commenter also wrote that they hoped the board would consider moving the window of the fee reductions to begin in January of 2026 instead of July of 2026. The board's recommended response rejects this suggestion. The board has proposed the start date of the fee reductions window at the beginning of the fiscal year based on calculations which determine the appropriate amount of time necessary to reduce the reserve fund to an appropriate level. Extending that fee reduction period may lower the reserve fund beyond the board's intention. From Attachment U, on October 9th, 2025, the board received written comments by Shanti Ezrin, MPA, and Kathy Atkins, JD, Deputy Executive Director from the California Association of Marriage and Family Therapists, also known as CAMFT. Commenter requested clarification as to whether the reductions extend to subsequent registration fees. The board's recommended response clarifies that the fee reductions include all application, registration, and renewal fees. Commenter stated that the board's processing times for licensure applications exceed 60 days per California Code of Regulations, Section 18005.1. Commenter questioned how the fee reductions would impact staffing or processing demands and whether the board would consider submitting a BCP to access reserve funds. The board's recommended response explains the fee reduction does not impact the board's position authority nor budget allocation for personal services. Therefore, this should not impact processing times. Additionally, the board is actively engaged in reviewing staffing and workload levels to ensure processing demands are adequately met and will explore all options available to continue working towards the board's processing target goals. Commenter requested the board consider shortening the fee reduction window to 1 or 2 years instead of 4 to protect the board's fund from general fund loans, economic uncertainty, and costs from major policy initiatives. The board's recommended response includes information that at current estimations, 1 or 2 years of reductions will not reduce the reserve fund enough to be compliant with Business and Professions Code Section 128.5B. Additionally, if the board is not in a financial position to loan money to the general fund without compromising operations, those funds will not be lent. Finally, 15 months or greater of months in reserve should be sufficient to cover implementation of major initiatives. Within the 4 years proposed for these reductions, the board will have sufficient time to re-examine the prior and reduced fee structures to determine the need for further adjustments while safeguarding its resources for expansion and economic uncertainty. The board may reevaluate the duration of the proposed fee reductions at any point after implementation. If necessary, the board can consider shortening or extending the fee reduction period as data becomes available. At the public hearing, one public comment was received from Shanti Ezrin on behalf of the California Association of Marriage and Family Therapists, CAMFT. This comment summarized CAMFT's previously submitted written comment, and the recommended response to this comment for the board is the same as for the original written comment. Board staff and legal counsel have not recommended any changes to the text in response to the public comments received. For this part of the agenda item, staff recommends the board consider the comments and approve the recommended responses. In Part B of this agenda item, the original proposed text changes approved by the board at its May meeting are provided for the board's consideration. Staff recommends that the board review the proposed regulatory text shown in Attachment A and consider whether to approve it as written or to suggest changes to the proposed text, then, after review and discussion, make a motion.
Thank you for the great report. Christy, did you have anything you wanted to say?
I think she covered it, but just remember, again, this is a two-step part to this process. The first one is to go over the comments and see if you want to make any changes to the responses we're recommending. So that would be the first motion. We don't get to the text till the second motion.
Okay.
Thank you.
So I'd like to make that motion, if I may, to accept the comments help me with the language here from the public hearing.
So the motion's on page 17, and if you agree with the staff recommended responses, the motion would be to direct staff to proceed as recommended as specified and provide the responses to the comments as indicated in the staff recommended responses.
Thank you. So I'd like to make that motion as duly stated.
Do we have a second?
Second.
Great. Let's go to public comment then on this one. Do we have any comments from our in-house audience?
Hello again, Shanti Ezrin with CAMFT. Want to just start by reiterating our support of the adjustments to reduce the board's fee structure, as we believe these reductions will help ease some of the financial burden on registrants and licensees. Now, we appreciate and we also understand the responses to our comments regarding the board's management of its reserve levels and the duration of these fee reductions. So just want to thank the board and staff for your continued commitment to evaluating staffing needs and also improving processing timelines. And on top of all that, too, staying mindful and open to reassessing the fee structure as future economic conditions continue to evolve. Thank you.
Thank you. Any other public comments in the room? Seeing none. Moderator, would you open online comments, please?
Yeah, we are taking public comment on the motion. If you would like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a few more seconds to see if we have a request for public comment. Seeing no request online, do you wish to continue?
Yes, thank you. Just checking in. Board members, any final comments before we vote? Seeing none. Christina, would you please take the vote?
Yes. Rebecca Thies,
Yes.
Dr. Annette Walker, Kelly Ronasinghe,
Yes.
Susan Friedman, Dr. Nicholas Boyd,
Yes.
Wendy Strack,
Yes.
John Sovek.
Yes.
Christopher Jones.
Yes.
Lorez Bailey.
Yes.
Motion carries.
Okay. Now we need to move on to the second motion.
Correct. So the second part of the action we need is for you to adopt the amendments as proposed. And so that would be motion A on page 18 to approve, if you agree, then no further changes are needed, to approve the proposed regulation text for CCR sections 1816, 1816.1, 1816.2, and 1816.4 as set forth in attachment A, and direct staff to take all steps necessary to complete the rulemaking process, including the filing of the final rulemaking package with the Office of Administrative Law, authorize the executive officer to make any non-substantive changes to the proposed regulations and rulemaking file, and adopt amendments to Title 16, CCR Sections 1816, 1816.1, 1816.2, and 1816.4 as set forth in Attachment A.
John
Anyone
Sovek,
with that
LMFT. I so move.
All right. We have a motion. Do we have a second? From Susan. Great. Any public comments from in the room? Being none, moderator, do we have any comments online?
WebEx, we are open for public comment on the second motion. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users, dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a moment now to see if we have a request for public comment. Seeing no request, do you wish to continue with the motion?
Yes, thank you. Right. Seeing no other comments, Christina, would you take the vote?
Rebecca Thies,
Yes.
Dr. Annette Walker,
Yes.
Kelly Ranasinga,
Yes.
Susan Friedman,
Yes.
Dr. Nicholas Boyd,
Yes.
Wendy Strack,
Yes.
John Sovek,
Yes.
Christopher Jones,
Yes.
Lorez Bailey,
Yes.
motion carries.
Just a real quick shout out to Rachel Lanzoni for all the hard work she's done. I want to thank her for the work she's done on this package. Thank you.
And thank you for all your help along the way. I really appreciate it.
A good presentation. Thank you.
Thank you.
Good job. Okay, moving on to item 33, update on board-sponsored and board-monitored legislation. And Roseanne.
Yes, so between last board meeting and this board meeting, we had the end of the 2025 legislative season. So the governor had until mid-October to make a decision on all bills that were on his desk. So a few updates for you on the status of proposals that the board sponsored. SB 775, that was the board's sunset bill and also the bill that we used to sponsor several of our provisions. So happy to report that the board's sunset date has been extended to January 1st, 2030. Also, several board-sponsored provisions were signed by the governor. What? Okay. So we had amendments to potentially allow the board to adopt the Association of Marital Family Therapy Regulatory Boards, or AMFTRB, Marital and Family Therapy National Exam as the clinical exam. That bill contained the first step in that process, which was allowing our board to even have the option of doing that via regulations, allowing that possibility via statute. So that has been done. We also deleted the sunset date to allow supervision via video conferencing in all settings. So that will now be allowed indefinitely. The sunset date is gone for that. And then we made some amendments to the licensing requirements for licensed educational psychologists. Another bill that was signed by the governor that the board supported was AB 489 by Assemblymember Bonta. And this bill would prohibit a person or entity who develops or deploys an artificial intelligence or system from having that system represent or imply that it's a licensed healthcare provider. So that bill is significant because it makes violations subject to the jurisdiction of the applicable licensing board. And currently, up until now, our board has only had the ability to take enforcement action against an individual, not a company or a business entity. So that is a first step in sort of the legislation I think we're going to see ongoing related to AI. Another bill that the board supported that was signed was SB 497 by Senator Wiener. And that bill seeks to protect the privacy and safety of individuals seeking gender-affirming health care and mental health care in California, as well as the healthcare providers delivering these services by strengthening protections in law related to sharing of their healthcare information. And then finally, SB 744 by Senator Cabaldon. This bill safeguards California's higher education institutions by providing that any national or regional accrediting agency that was recognized by the U.S. Department of Education as of January 1, 2025, will retain that recognition under California law until 2029, provided it continues to operate in substantially the same manner. And that is important because our licensing requirements require USD accreditation in most cases toward licensure. So that will be staying the same no matter what happens. And that bill is signed. A couple of bills that were vetoed, AB 742 and SB 641. I've included information in your packet on, it has a link to the governor's veto message explaining why he vetoed those. And I think that's pretty much all.
Thank you.
We got, should I mention it?
Either one of us do it.
Okay, well, just want to note that two board members have left, Board Member Walker and Friedman, but we still have quorum. So, thank you.
Do we have any questions on this item from board members?
So Roseanne, to your knowledge, has any board, launched the first foray into AB 489 by doing a cease and desist order? I'm really curious. Or are we going to be the first ones?
That's a great question, and we have started some internal discussions with DCA, and I think that we're going to be having a little bit more discussion in a couple of weeks at our legislative roundtable about that. But yeah, it is sort of a roulette wheel of like who's going to go first on that. I'm sure somebody will see it, and it's one of those things where it's sounding like we're going to kind of once the case happens, and depending on the details of the case, the legal will look at it and provide guidance to whoever that board might be. But yeah, it is a very new thing,
Okay.
as with everything is with AI. So yeah.
Any other questions from board members? Seeing none, do we have any questions from our in-house participants?
Hello, once again. Shanti Ezrin with CAMT. Roseanne, thank you for the updates on the legislative items here. And in regards to AB 489, like you said, the bill would make those violations of the law subject to the jurisdiction of the appropriate healthcare professional licensing board. Wanted to share that at CAMT, we're starting to get some questions on this and just would appreciate any early information, any guidance that you can provide on the implementation of this provision, like the process, how to direct complaints about AI chatbot therapy to the board. Thank you.
Yes, as soon as we have something, we will pass that along.
Thank you. Moderator, do we have any comments online?
WebEx, now is the time to raise your hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a moment longer to see if we have a request for public comment. Seeing no request online, do you wish to continue?
Yes, thank you. All right. Thank you, Roseanne. We'll move on to item 34, update on board rulemaking proposals. And Christy, we'll go to you.
Thank you. Okay, so the board's disciplinary guidelines regulation package has been approved by OAL, and that will it has a delayed implementation, so that will take effect July 1st, 2026. The approval documents are on our website, but we'll be releasing the actual updated disciplinary guidelines in its final form closer to July 1st. The telehealth regulations were also approved by OAL and take effect earlier, though. They'll take effect January 1st. The continuing education regulations, the status on here shows that they went to agency for review. They've gone through agency at this point, and so they're continuing in that review process, but we're expecting to send those out for the 45-day public comment period sometime very soon here. The advertising regulations were submitted to OAL for final approval on November 4th. They have 30 days to do their review. So we're expecting to hear from them soon. And we'll most likely have January 1st, 2026 approval date as well, or effective date, I should say. English as a second language, additional examination time. It's in the review process, and I believe it's with budgets at this point. And then the fee reductions, you heard about those today. The AMFTRB national exam, we are preparing the documents for the initial review process, and then the LEP experience, same thing. We're getting those ready. So, and that's all I have.
Do we have any questions from board members?
Can I interject something?
Yes.
Just give kudos. It was like a really quick note saying that the disciplinary guidelines are going to be going into effect, but the work that went into that, kudos, Christy, because that was an amazing haul.
Thank
So
you.
I don't know, you were all going through the process and you saw how all the cross throughs, strike throughs, keeping track of all that stuff. So thank you very much for that. That was excellent.
Thank you.
I'd like to second that as well. Chrissy did an amazing job. That was a huge project that had to be, for various legal reasons, we had to allow other regulations to go before it at some point. So it was accumulation of many years of work, actually, and very, very detailed as far as the regulation goes. And Chrissy did an amazing job. So congratulations and thank you.
Thank you. Okay. I'm going to go up for comments here. Okay. It's Friday afternoon. Any comments from our in-house participants? Seeing none. Moderator, do we have any comments online?
We are taking public comment on agenda item 34. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand. We will call on people in the order we have requests. We're going to take just a few seconds now to see if we have a request for public comment. Seeing no request for public comment, do you wish to continue?
Yes, thank you. That takes us to item 35. Suggestions for future agenda items. Do we have any suggestions from board members for future agenda items? Kelly?
So I would like to calendar an agenda item for an update on probationer fees and to what extent we can minimize the impact on probationers who are completing their probation requirements. In every hearing we have done, a probationer has indicated that the fiscal impact of probation is a barrier to completion. And it's actually one of the main reasons why they apply for early termination. So in criminal probation, the court also utilizes drug testing fees, but few probationers, because we're very intense about it, are tested with the regularity and for such an extended period of time. And just to give you an example, in 2019, the Legislative Analyst's Office published the overview of state criminal fees. In San Diego County, which has a very robust probation program, a low-risk case for substance abuse, alcohol use had a fee structure of about $2,000 over a 3-year period, which is very manageable. One of our recent probationers indicated he was paying nearly $4,000 over a year period, which is devastating, really, for an early practitioner. At the same time as he's doing substance abuse dependency support and individual therapy. So the objective of probation is not really to punish, it's to ensure safety. So I would like to calendar this agenda item to ask the executive officer if there's any mechanism to mitigate the fiscal impact on our probationers, either through our surplus fund or any funding channel. That's it.
Any other suggestions from board members? On future agenda items? Sorry, did you have one?
On probation, I was wondering whether we need a future agenda item on clarity of expectations during tolling periods.
Okay. On tolling periods? Just a presentation on.
No, clarity of expectations.
The what?
Just clarity of
Oh,
expectations.
clarity of expectations on tolling. Thank you. Okay, any other agenda items? Do we have any members of the audience with suggestions for future agenda items?
Thank you, Ben Caldwell, MFT. Hassan? Thank you, Ben Caldwell, MFT. As mentioned earlier, I'd like to request the board engage in a discussion about clinical exam validity and possible alternative pathways to licensure. I know that a lot of your work around exams has to occur in closed session, but the academic community and the professions at large appear to be gradually losing faith in the exam process as a valid or even useful component of the licensing process. In social work, as I understand it, NASW has formally withdrawn its support of ASWB's exams, and CSWE, the accrediting body, has removed exam pass rates as an appropriate measure of educational outcomes. Some states have removed exams at some levels of social work and created alternative pathways at other levels of social work, pathways to licensure that do not involve exams, with no apparent negative impact on public safety. In 60 years of use, clinical exams in mental health care have not once been shown to correlate with actual future safety or effectiveness in practice. They are a barrier to licensure and nothing more, which makes their outcome disparities all the more troubling. Steve, I'll be sending you a number of open access peer-reviewed journals that I believe can help inform discussion on this. I'll also reiterate the request that this be placed on the agenda with some urgency, given that these issues are relevant to how the board and staff presses AMFTRB for positive changes in its exam prior to implementation in California. Thank you.
Thank you. Any other comments in-house? Seeing none, moderator, do we have any comments for future agenda items online?
WebEx, now is the time to raise a hand for future agenda items. If you'd like to make a comment, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. We're going to take just a moment now to see if we have a request for public comment. Seeing no online requests, do you wish to continue?
Yes, thank you. Okay, moving on to item 36, public comment for items not on the agenda. I'll now open for public comments for items that are not on the agenda. As a reminder, the board may not discuss or take action on any matter raised during this public comment section, except to decide whether to place the matter on the agenda of a future meeting. Each commenter will have 2 minutes. Do we have any board members with comments for items not on the agenda? Seeing none, do we have any in-house comments on items not on the agenda?
Good afternoon, and thank you again for the opportunity to speak. My name is Rick McCarthy. I'm an LMFT with nearly 50 years of clinical experience, 28 years as a professor and supervisor, and over 25 years as a subject matter expert and oral examiner for this very board. I have helped write, administer, and refine the licensing exams that were once the gold standard in our field. I'm here again with the same concern. We're in a mental health crisis, and we need to reinstate the oral exam to better protect the public. We currently license therapists based solely on written exams. These tests may assess knowledge, but they do not and cannot evaluate the interpersonal, ethical, and emotional skills that are essential to safe and effective therapy. Real-time clinical judgment, the ability to hold therapeutic boundaries, and professional presence are all invisible on a multiple choice exam. We are responsible for lives, for preventing suicide, for intervening in domestic violence, for reporting child abuse, for holding space for trauma. Yet we've eliminated the only tool that ever allowed the board to see whether someone could do this work in real time. I understand the argument for efficiency, but the board's primary duty is not to make the process easier or make candidates happy. The public believes your duty is to protect the public, and we cannot protect what we do not assess. One of the concerns that have stayed with me since the oral exams were removed in 2003, at that time, the passing rate for the oral exams was around 35%.
15 seconds.
Today, the BBS issues roughly 20,000 LMFT licenses a year. Assume only 50% of these candidates would have failed the oral exam. We must ask, how do we justify licensing so many individuals who
Time.
lack basic clinical competence? Does the removal of the oral exam mean that those previously deemed incompetent are now somehow qualified simply because the standard no longer exists? It isn't punitive, it's responsible. This isn't gatekeeping, it's guardianship. The public still trusts us. They assume that when we walk into a therapist's office, that someone, you, made sure the therapist is safe, sound, and competent because the therapist was effectively evaluated through the oral exam. Please take this seriously. The integrity of our profession and the safety of the mental health of the people we serve depend on it. And anything I can do to help, I'm at your service. Thank you and happy Thanksgiving.
Good afternoon. My name is Kelly Michael Kilcoyne. I've accumulated over 30 years direct client contact experience providing mental health services for underserved and marginalized individuals in community mental health programs in San Francisco, Contra Costa, Alameda, and San Mateo counties. In the last 15 years, I've been working in private practice as an MFT in a Medi-Cal contracted private practice. I'm here today to endorse the points made by Mr. Rick McCarthy. In preparation for coming here, I took a look at the Sunset Review report that the board published in 1997, and I'll quote, "License examination by the board provides a function of minimizing the number of unqualified people who enter the field it regulates and reduces the chance of harm to consumers. An accurate diagnosis and well-implemented treatment could be the difference between life and death for some people in therapy. I believe that increased rigor in the licensing process by restoring the oral examinations ensures the board will become better able to validate qualified practitioners for the public good and decrease the likelihood of less competent, potentially dangerous practitioners entering into the profession. I think it's safe to assume that everybody here is here because we care about the future. We care about our profession, and we care about the future generations of therapists. I think that oral examinations...
15 seconds.
I think that oral examinations can help applicants have an opportunity to demonstrate their clinical acumen, and I ask that the board consider that oral examinations possibly be included in the process in some form of an incentivized option for such candidates. Thank you very much.
Thank you. Moderator, do we have any online comments?
All right, WebEx, if you wish to make a comment for items not on the agenda, please raise a hand by tapping that hand button at the bottom of the screen. Dial-in users dial *3 to raise your hand, and we will call on people in the order we have requests. And our first request is coming from area code 408. Hold on just a moment, please. We're going to send you a request to unmute your microphone. Given the comments before, you'll be given 2 minutes to speak, but if you need just a little bit more time to finish up, that's okay. Hold on just a moment. 408, you'll need to dial *6 to unmute.
Can you hear me?
Yes, go ahead, please.
Great, thank you. This is Dr. Lisa Weninger again, LPCC. These are Apologies, these are a little half-baked thoughts. I'm part of a national organization called Counselors for Social Justice, which is a division of the American Counseling Association. The accreditation organization for counselors is called CACRED. Because of the anti-DEI legislation and executive orders that have been coming through our country in different places, not in California, but nationally and in very specific states, there has been impact to the counseling profession to the extent of changes happening in many state counseling programs, master's level counseling programs, where the curriculum has had to be changed to comply with these state anti-DEI policies. For example, multicultural counseling program classes have had to be changed. I don't really know what I'm asking for, but I wanted to make sure that this is on the radar for the BBS, and even to the extent of potentially putting in some kind of a shield law, which I don't know if that even can be generated from the BBS or it needs to be outside. I don't know the process well enough yet, but putting in similar to what the protecting gender affirming care was written into the law, so that has greater protection in our legislative code. I'm wondering if there is a possibility, just to, again, to raise awareness that this is happening in other places where it's literally changing the standard of care within counseling, and I'm sure other professions as well, and to see what kind of proactive action can happen in
15
California
seconds.
to protect our profession and to protect our clients. Thank you so much.
Thank you. And next, we're going to hear from Kendi Fay, who is potentially our last commenter. Hold on, Kendi. We're sending you a request to unmute your microphone.
Hello, good afternoon.
Good afternoon. Go ahead, please.
Thank you so much. Thank you for everybody who spoke as well. My name is Kendi Fay. My pronouns are she, they, ella. I am a trauma therapist specializing in perinatal mental health and birth trauma specifically. I'm also pursuing doctoral research at the intersection of birth, institutional care, and power dynamics. Specifically with regard to the conversation that was happening today around continuing education in perinatal mental health, as well as changes to fee structures, as well as the comments recently made on restoring the oral exam and this notion of safety for our clients in our care and protection. Implicit bias, returning to some of the earliest points of today's meeting, is prevalent throughout our field and is becoming more explicit with the national mandates and changes in legislation that are starting to unfold, as was just commented on. So I would like to just raise, I wasn't planning on speaking in this portion, but I'd like to contribute this comment that as the board is considering changes, that they're also considering how to incorporate accountability for implicit and explicit bias of those who are writing the exams, monitoring, marking them, designing them, and also how clinicians are being evaluated in supervision and how we're evaluating and assessing our own clients. Many clients are even not well represented in the evidence.
15 seconds.
Meaning providing evidence-based care for people who are multiply marginalized is already in the realm of unethical treatment because there's not even so much evidence for how we treat them. So this is a concern I'd really like to make explicit here. Thank you.
Thank you. And those are all of our online requests.
Thank you very much. Moving on to item 37, which is adjournment. Thank you all for participating over the last 2 days. We hope to see you all at our next board meeting, and that will be February 19th through 20th, 2026. The meeting is adjourned.